அன்பிற்கினியவர்களுக்கு இனிய காலை வணக்கம். திருக்குறளும் திருவருட்பாவும் சிலப்பதிகாரமும் சீவக சிந்தாமணியும் மணிமேகலையும் கம்பராமாயணமும் நற்றிணையும் குறுந்தொகையும் அகநானூறும் புறநானூறும் மூதுரையும் நெடுநல்வாடையும் ஆருயிர்க்கெல்லாம் ஆத்திச்சூடியும் அள்ளித் தெளித்த என் தாய் தமிழே, என் தெல்லு தமிழே, என் அருஞ்சுவை தமிழே, எங்கள் கொங்கு மண்ணே, கரை புரண்டு ஓடும் காவேரியே, மஞ்சள் மணமே, பருத்தி காடுகளே, மல்லிகை தோட்டங்களே, நம் மாநகருக்கு மனநலம் எனும் மாநலம் காக்க வந்து இறங்கியிருக்கும் ஆன்றோர்களையும் சான்றோர்களையும் பகுத்தறிவு பகலவன் பிறந்த நம் கொங்கு மண்ணின் மரியாதையுடனும் மஞ்சள் மனத்துடனும் மோப்பக் குலையும் அனிச்சம் முகம்திரிந்து நோக்கக் குலையும் விருந்து என்ற வள்ளுவனின் வார்த்தைக்கேற்ப அனைவரையும் இன்முகம் கொண்டும் இருகரம் கூப்பியும் வணங்குவோம், வரவேற்போம். இந்த தொடர் கல்வி பயிலரங்கத்திற்கு தமிழகத்தின் பல்வேறு பகுதிகளிலிருந்தும் எம் மண்ணின் பெருமை காண வந்திருக்கும் மண்ணுலகில் மக்கள் மனநலம் காக்கும் எங்கள் அன்பு மனநல மருத்துவர்கள் அனைவரையும் வருக வருக என்று கரைபுரண்டோடும் காவிரி போன்று தெளிவுடனும் எங்கள் கொங்கு மண்ணின் மஞ்சள் மனமுடனும் எங்கள் பாட்டன் தீரன் சின்னமலையின் துணிவுடனும் ஈரோடு மாவட்டத்தின் மனநல மருத்துவர்கள் அனைவரும் உள்ளார்ந்த நேசத்தோடும் பேருவகையோடும் பேரன்போடும் உளமாற வரவேற்பதில் அகமகிழ்கிறோம். இனிவரும் 2 நாட்களில் நீங்கள் உணரப்போகும் எங்கள் ஊரின் கொங்கு மண்ணின் மரியாதையும் மஞ்சள் மனமும் உங்கள் மனம் விட்டு செல்ல பல காலங்கள் ஆகும் என்ற உறுதியோடு இன்றைய நாளை துவங்குவோம். எங்கள் அழைப்பிற்கு அன்பு செலுத்தி இங்கு வருகை புரிந்திருக்கும் உங்கள் அனைவருக்கும் எங்கள் மனம் நிறைந்த வாழ்த்துக்கள், நன்றிகள், வணக்கம்.
A very good morning and a warm welcome to each and everyone of you gathered here for the Midterm CME for practitioners organized by Inaugural Mental Foundation and Indian Psychiatric Society, Untitled Chapter.
We hope you will have a good time here and the topics will be insightful to you. We have an excellent lineup of speakers who will be sharing their knowledge and expertise. So without any further delay, we will go ahead with our first session. Predicting the Mind, New Frontiers in Prodrome At-Risk Mental States.
Let's welcome our honorable chairpersons for the first session, Dr. T. Kumanan, MD, DPM, retired professor and head of the department, Madurai Medical College, and Dr. Sabida, professor and head of the department of psychiatry, Stanley Medical College, Chennai.
Let's welcome our speaker, Dr. Nirmal, principal, MEU coordinator, professor and former HOD, Psychiatry Department, Dhanalakshmi Srinivasan Medical College, Trichy, for his mindful presentation.
இது மட்டும்தான் பேசணும். ஓகே, எல்லோருக்கும் என் காலை வணக்கம். இந்த நல்ல தமிழிலே கேட்டுவிட்டு திரும்பி ஆங்கிலத்தில் பேசுவதற்கு கொஞ்சம் கூச்சமாக தான் இருக்கிறது. நம்மளுடைய மனநலம் ஆங்கிலத்தில் தான் நாம் பேச வேண்டிய ஒரு சூழ்நிலையில் இருப்பதனால் இப்போது அட்-ரிஸ்க் மென்டல் ஸ்டேட்டஸ் அதுதான் சொல்கிறாங்க. வென் வி வேர் ஸ்டூடெண்ட்ஸ் அது 2 கண்டானா இருக்கான் அப்படின்னு சொல்லுவோம், ரைட்? அந்த எய்தர் ஹீ இஸ் சைக்காட்டிக் நார் ஹீ இஸ் நார்மல். ஸோ ஹவு டு டேக் ஹிம், தட் இஸ் த ப்ராப்ளம். ஓகே, ரைட். ஹீல் ஹாவ் சம் சிம்டம்ஸ் லைக் ஒரு ஸ்லீப் டிஸ்டர்பன்ஸ் or some odd behaviors or some fleeting perceptual disturbances which we cannot quantify or qualify into any of the psychiatric disorders, but still whether we'll have a doubt whether he has to be treated or not, but still we have to intervene. That is the thing. If they are intervened early, I think the recovery is better. Sometimes it goes off like that also. So where we have to intervene and what has to be done to those persons is very, very important. That's what, that is the topic today. And we have this attenuated psychosis in DSM-5 actually. Okay, right? So why you call it that way and what has to be done to those persons? I think Dr. Nirmal will highlight on that. And about the speaker, the co-chair will do.
Good morning, all. I welcome you all for our this year's CME, which was started, I think, in 2007 by Dr. Anandan. I'm happy to be here, this annual function, and thank the organizers, Sadanand, Jayaprakash, and his team, yes, Saravanan, Navanidan, for giving me this opportunity. Before going to the introduction of speaker, just one word about this Prodrome. Prodrome, you would have heard about the punch dialogue. நான் எப்போ வருவேன் எப்படி வருவேன் தெரியாது, ஆனால் நான் வந்துடுவேன், கட்டாயம் வந்துடுவேன். அது மாதிரி இல்லை, எப்போ வந்துச்சு எப்படி வந்துச்சு யாருக்கு தெரியாது. This is a process. I used to equate this with sleep. For example, if you say when you are feeling sleepy, you have already slept. You have not experienced the onset of the sleep. Before you realize that you have started sleeping, you are already in the phase of sleep. If you record the EEG, it will show. Just like that, this Prodrome is very confusing. Even after 30 years of service, I do not worry about Prodrome at all, because we don't get any cases at Prodrome phase. Our people are not intelligent enough to refer or to sense that the patient is having any abnormal behavior. So with these few words, I will introduce the speaker. Dr. Nirmal Abal is my close friend. I have gone to his college for inspection many times. He is undergraduate student from Sri Ramchandra Institute of Health Education Research, Chennai, and he did his PG from CMC Vellore. He was a teacher for CMC Vellore, KIMS, and High Tech College. Yes, he has published national papers in national level journals and international level journals, and presented in the International Congress of 5th European Congress of Violence in Clinical Psychiatry, Amsterdam, and national level conferences. He was the speaker in TAN Psychon in the last meeting also, I think so, in Coimbatore also, Midterm CMEs. The awards received are Dr. Abraham Varghese Prize for Research from CMC Vellore, Dr. B.C. Das Award for published papers in 2008-9 from IPS Orissa branch, is Best Individual and First Prize in Group, Individual and Group Prize, First Prize in Brief Course in Psychiatry Research in 2022, organized by the RCBS of our South Zone branch at St. John's Medical, Bangalore, and ASAN 24 Award for Excellence in Medical Teaching by IMA MSN, Award of Clinical Excellence from DSCH in 2024. Dhanlakshmi Srinivasan is college where he is working, and I welcome Dr. Nirmal to start our this year's academic venture. Welcome, Nirmal.
Thank you, sir. Good morning, all. I thank the TNIPS president and the team for inviting me to deliver a speech, and I thank my Trichy colleagues who had probably recommended me to present here. And this is the second time I'm having Kumanan sir as my chair. So first time into the 2019 10 Psychon, I think. And sir said, ma'am, we have interacted very less, but madam, we've been following in the past. So as sir said, he's come to our college frequently and all. So good to start from here. இப்போ அவங்க சொன்ன மாதிரி தான், இப்போ வந்து ஒரு எனக்கு கேட்கும்போது எல்லாரும் பேசுகிறது தான், இது என்ன டாபிக், ஓகே சார் கேட்டார், ஓகே பண்ணுவோம். ஸோ அந்த மாதிரி தான் எடுத்து பண்ணது. பட் பேசிக்லி I'll be talking both about prodrome and at risk, and how we can predict probably what's going to happen in these people, and what evidence says about predicting and intervening there, and just a sec. Just a sec, give me a sec. Not minimize, okay, here. Sure. Thank you. So the objectives of the session will be at the end, the participants will be able to understand the concept of prodrome and its relevance in psychiatry, identify the clinical markers and early warning signs of major mental illnesses, recognize and assess at-risk mental states, discuss early intervention strategies and preventive approaches, and most importantly, our president sir was specifically saying again and again, it is for practitioner CME, so konjam theory குறைச்சிருங்க, apply பண்ற மாதிரி பேசலாம். Apply these in their clinical practice. I hope I'll be doing these in my presentation. So before we start, if all of you have smartphones, so go to slido.com and join us. If you have not registered earlier, it's okay. Join as guest and type the predict and keep. So there will be a series of 3 or 4 interactive things which you could interact from your mobile phones. You could either scan the QR code or go to the slido.com and keep it ready. I'll go to the next slide. Okay, so these are the two things which we are going to talk, prodrome and at risk. So if prodrome is A and at risk is B, are A and B of the same color? So, okay, Lada, Gopi, fine. Okay, now can we start the, okay, yeah. Now you could say, so you could answer yes or no. It's a simple question. That's why I gave only 15 seconds. Or if you have not done, we'll go back again. Well, I think not many have. Okay, 50% yes, 20% no, can't say. Okay, let's make it a little bit simpler. So, Preeti, Gopi, okay. This is one series of questions, it will be good, but okay, I'll skip this for now. Actually, if you see, now they are same or different? Still not clear? You see, they are the same. The difference is the borders, and if you see, there is a gradient. Here it is darker and here it is lighter. So it gives appearance. In spite of seeing this, if you still see this, you will still think they are different, but they are the same. So I'm not going to confuse you saying they are the same, but the concept of prodrome at risk get confused many times, and even researchers sometimes club things together and do. So hope I will clarify further in our future sessions. So why should we recognize earlier and what does it matter? We all know. So most of our psychiatric disorders start, the initiation is somewhere in the late adolescence or childhood. So 1 in 5 people have their onset before 25, and among them who have the onset, 50% are starting by 14. And generally mental disorder begin as non-specific psychosocial disturbance, as ma'am was saying, vague symptoms. So these things, and they can present to major mental disorders, and this contributes to 45% of the DALY in the age group, in the 0 to 25 age group. So these are the reasons we should be able to identify. And the good news is, so delay in diagnosis can worsen long-term prognosis, and mental health problems can significantly affect the personal and social functioning. So therefore, if you intervene early, the functional outcomes can be improved, the quality of life can be improved, and either we can prevent the onset, or if not, at least we can reduce the relapse rates. Hospitalization can be reduced, and through awareness, patients and caregivers are more empowered to tackle their problems when they arise. So prodromes at risks are there in many other fields also. For example, most infective diseases, there is a prodromal phase, and even diseases like cancers and all, there can be some prodromes. But what is specific and what is challenging in psychiatry is, one, the dynamism of our disorders. We in our practice we would have seen, we would very confidently say this patient is this. இன்னைக்கு இருக்க பிக்சரை பார்த்தா ஸ்கிசோஃப்ரெனிக் தான், இது வந்து பைபோலார் தான். ரொம்ப ஸ்ட்ராங்காக நம்ம ஈவன் சீசன் கிளினிஷியன் சம்டைம்ஸ் வி மேக் அ டயக்னோசிஸ், இந்த டிமென்ஷியா ப்ரீகாக்ஸ் ஃபீலிங்லாம் சொல்கிறோம் இல்லைங்களா, அந்த மாதிரி. பட் லேட்டர் ஆன் வி வுட் ஹவ் சீன் ஸோ மெனி பேஷண்ட்ஸ் ஹூ சேஞ்ச் டயக்னோசிஸ் ஃப்ரம் bipolar to schizoaffective, schizophrenia to schizoaffective, and many recurrent depressive disorder patient, lifelong having depressive episodes, requiring even 2 or 3 antidepressants, doing well, suddenly after 15, 20 years, developing a manic episode. So it is very difficult to understand the dynamic nature, and that is probably because of the more plastic nature of brain and the psychiatric presentations. And many cases are, Kumran sir சொன்ன மாதிரி, are very difficult to diagnose in the early stages because one, they don't present. But many times, not only our clinicians, we get referrals from faith healers. அவங்க சொன்னால் நம்மகிட்ட பேச்சே கேட்காம வந்துடுறாங்க. நிறைய இடத்துல போனோம் சார், இது வந்து எங்கள் பிரச்சனை மாதிரி இல்லை, இல்லை இல்லை பேயும் ஓட்டிட்டேன், அவரையும் போய் பாருங்கள். ஸோ ஒன்லி வென் தோஸ் கைண்ட் ஆஃப் ரெஃபரல்ஸ் கம், பீப்புள் கம் வித்தவுட் கொஸ்டினிங். And it is difficult to identify and refer also. And even our colleagues feel it is difficult to refer a patient to us. ஏதாவது சொன்னாலே நான் என்ன லூஸா? So I used to say it is not what you do, it is how you do. எப்படி எங்களையும் ஒரு டீம் மெம்பராக நீங்கள் இன்ட்ரடியூஸ் பண்ணலாம், என்ன பண்ணலாம். ஸோ அந்த மாதிரி, ஸோ we get very rarely we get people at early stages unless we have population level strategies from the government. It's difficult to catch people who have early symptoms. We'll be discussing in the future. And lack of specificity of earlier symptoms. Many symptoms are commoner to psychotic disorders, mood disorders, personality disorders. So it is very difficult to identify. இப்போ ப்ரோட்ரோம் சொல்கிற மாதிரி, ப்ரோட்ரோம் வந்து மேடம் சொன்ன மாதிரி இப்போ வருவேன், எப்போ வருவேன் தெரியும், ஆனால் கட்டாயம் வந்துடுவேங்கிற மாதிரி. வேறஸ் அட்ரிஸ்க் வந்து வரும், ஆனால் வராது. ஸோ இட்ஸ் வெரி டிஃபிகல்ட் டு ஐடென்டிஃபை. ஸோ அண்ட் ஒன் மோர் கான்செப்ட் இஸ் different prodromal signs, will they lead to a common diagnosis? So these symptoms, இப்போ ஒரு neurotic symptoms இருக்கலாம், ஒரு mild subthreshold psychotic symptoms இருக்கலாம், whether these will lead to schizophrenia or whether we'll have multifinality where any diagnosis is possible. The patient may become affective disorder patient, he may become a psychotic person, or he may develop substance eating, or he might even get away without developing a problem. So it is very difficult to predict, even with these set of symptoms, what diagnosis they will develop or whether they will develop or not. So coming to the first phase of it, so talking about prodrome. So prodrome is ideally we catch it before the break, before there is a presence clinically. So the beginnings can be silent, and the concept is that if you catch early signs and you recognize early, you can intervene effectively and thereby produce good effects. But ideally, prodrome studies are retrospective studies. In the sense, you cannot catch prodrome when it comes. Most of the studies have identified people with disorders and retrospectively gone back to find out whether these persons have had prodromes. Now, probably with the group of symptoms, when it is presenting together, when we are not clear, we may think this might be a prodrome. So ideally, prodromes can be definitely diagnosed only after the onset of the disease, at least theoretically speaking. So again, you can go back to Slido. What comes to your mind when you think of prodrome? Here you need to type maybe a word or a phrase. Your responses can come there. This is basically to say that most of what I'm going to say, as clinicians, you will all be knowing it earlier. And generally, knowledge is built only if it is constructed on what is already known. Very early. Okay, sorry, I didn't go. Okay. Just a second. We'll wait for further. So, but all of us, when we think of prodrome, although, stressed very early, but hey, this should not go this way, sorry. So, but most of us are hinting towards psychosis, schizophrenia, because நம்ம படிக்கும் போதெல்லாம் prodromeங்கிறது they have only focused on psychosis. But as everybody is pointing out, silent, what to do, wait and watch, blunt effect, early, stress, okay, retrospective. Fine. You have covered most of the points which I'm going to discuss. So basically, it's a derived from a Greek word, prodromus, which means it's a forerunner or a precursor for something. So basically, a period of early and non-specific symptoms. So it's not specific, it's non-specific symptom before full-blown illness. And Fava and Kellner define as early symptoms and signs, including signs also, that precede the acute clinical phase of an illness. And not only psychosis, they can be noted even before mood disorders and, as I said, other substance use disorders, and also dementia. And the point we should focus is it presents a critical window where we can intervene early, and if you spot the prodrome, there is a possibility that you could change the outcome. In fact, prodrome and at-risk states are where psychiatrists are seen as disease modifiers. They're able to modify, although we treat and modify in most cases, but here you intervene before it starts, so you're able to produce a marked change in the lives of the patients. And it can include mood changes like irritability, apathy, behavior like withdrawn behavior, cognitive functional deficits, not only thought disorders like fleeting psychotic symptoms, they can also have cognitive problems like attentional deficits, verbal fluency problems, working memory problems. These all can happen in prodrome. And they precede the full episode by weeks or months. And recognizing, as I said, is crucial for early intervention because they can improve patient outcomes and prevent the potential full development of a disorder. But as I was earlier saying, by theory, a prodrome is always a precursor. So, vandaduna ipo illatiyum definitely pinala vandurum. Abdin stronger sollumbodha we can strongly say prodrome, and thereby prodrome can be usually retrospectively diagnosed. So, in a prodrome, when will you be careful? When will you intervene? Is when there is a changes in behavior or affect, and there is a decline in functioning. Along with, usually they say a prodrome, and later on, late prodrome, they include attenuated psychotic symptoms and others. So, if these emergence, suspiciousness, anxiety, personal changes, it can be bordering into probably, and it is waiting just for an environmental factor or something to precipitate and produce a disease. Sleep disturbance, emotional blunting, and apathy, these are red flags where you should think it is probably a prodrome which is going to manifest. And one strategy which they followed in medical specialities and also in Australia is to identify the co-presence of prodromal symptoms. ஒரு symptom மட்டும் இல்லாமல் என்னென்னலாம் இருக்குது இந்த மாதிரி co-presence identify பண்ணி thereby they come up with a state trait model where the trait could include family history, schizotypal features, all those things, and state could be the brief psychotic symptoms, the attenuated psychotic symptoms. So when these come in, we close in and try to identify it as a prodrome of that particular disorder. Now coming to the next part, I will club studies on both together and discuss later. So next is the at-risk mental status. So here we are identifying it early. There are early warning signs. The disease is already set in. I mean, I'm going to say risk factors are there, and the first hints are seen, and if you intervene here, you will get a better outcome. So, contrasting to prodrome, here the studies focused on at-risk are prospective studies where they have identified, they have defined certain set of criteria to identify people with risk. Initially, most studies are focused on psychosis. Later on, there are other studies also, and then they have either monitored long-term or intervene with brief therapies, cognitive behavior therapy, pharmacological drugs, and identified whether we are able to reduce the transition rate or change the severity of the symptoms or the distress associated with the disorder. So these are prospective studies, as I was saying. So again, going to the slide. So what is at-risk mental state? What comes to your mind? அந்த சேம் கோட் தான், சேம் கோட், சேம் ப்ரிடிக்ட் தான். If you open, the current question will come. நீங்கள் இவ்வளோ நாளாக கவனிச்சிங்களாங்கிறதுக்கும் டெஸ்ட் வச்ச மாதிரி ஆகிடுது, எக்ஸாமில் இருக்க மாதிரி தான். We usually tell our students, அட்லீஸ்ட் கொஸ்டின் பேப்பரை முழுசாக படிங்கடா, பாதி ஆன்சர் அதிலே இருக்கும், அதை கூட படிக்காமல் விட்டுறாதீங்கிற மாதிரி. I don't know why it's getting skipped actually. Okay, be watchful, stress, risk of doubt. Any time they can break. Risk to develop mental illnesses. Okay. Slides போதுங்குது போல, sorry. So first, before going to at-risk states, we all know about risk factors in medical diagnosis. We know risk factors for cardiovascular disease, risk factor for CVA. So what are risk factors? They are a set of characteristics, variables or hazards, if present for a given individual, makes it more likely that this individual, compared to someone else from the general population, will develop a disorder. So basically these are risk factors. So presence of one or a few set of factors in a person definitely makes it likely that he, compared to another person from the population, develops a problem. So applying this to risk syndromes, in psychiatry we are always identifying syndromes. So risk syndrome is amalgamation of one or more of the clinical symptoms and putative precursors which acted together increase the likelihood of transition to a psychiatric disorder. So this is called a risk syndrome. So we have a group of symptoms, and the group could be both the neurodevelopmental and neurodegenerative models explain these kind of things. So there could be a biological factors, and there could be psychological and social contributors. So they're waiting to break. So when these set of factors join together, a combination of state, trait and family markers can make a person develop a risk syndrome, which puts him in the risk of developing a future mental disorder. The major advantage of a risk approach compared to prodromal approaches, prodrome, as we said, it has already come. Whereas in risk, it might come. And it not only focuses on risk factors, there is a focus on protective factors also. In fact, the anti-psychiatric movement and everything was, one accusation they had against psychiatrists was, we are labelizing, we are pathologizing. So we are talking about pathology, not about positive mental health. That's where psychologists come in and they do a lot of practice and others. So the at-risk model focuses also on protective factors. So thereby you will be able to identify and help strengthen the protective factors and probably reduce the risk factors wherever possible. And as I said, in prodrome, when we mean prodrome, actually, as I said, it definitely should end up in psychosis or in a major disorder. So it is inevitably ominous prognosis, whereas at-risk is potentially preventable. So that's why the recent research has shifted more towards at-risk models, and then there is a gradual shift towards trans-diagnostic model, which I'll discuss, because we will be able to intervene and there we will be able to do show some improvement there. So what are at-risk mental states? So these are either subthreshold symptoms which indicate high risk for psychosis. Initially, this was the UHR ultra high risk criteria. So where the patient should have the DSM-5 appendix attenuated psychotic symptoms, where there is a subthreshold syndrome. We are not able to diagnose a psychiatric disorder, but there are definite psychotic symptoms. And blips is it's like recurrent minor depression, brief, limited, intermittent episodes. There is a psychotic symptom, there is an episode, but it improves within a week. So they're not able to, it doesn't qualify for even a ATPD. And along with it, there is a genetic vulnerability in the form of family history of psychotic disorders or individual history of schizotypal personality, schizotypal disorders. And then there is a functional decline. So most of these ultra high risk individuals are defined as people who have some decline and who are presenting to us, help seeking or referred for psychiatric help. Although it is not sure what disorder, they are referred. So most of the risk criteria I have taken only people who have been help seeking. So here we can help to identify individuals before the conversion to psychosis. And the core idea is prevention through prediction. Predict and spot the risk early and try to prevent. And certain classical models which we've been routinely using in psychiatric teaching is one is the etiological model, one is the biopsychosocial model by Engel, and the 4P factor model. PP Kannan sir is there. So his students say, sir expects this in every single case presentation. My PGs are doing it, sir. So they are filling up all these things. So this is one area where we are looking into various factors, not only biological, psychological and social factors, which can be modified in that particular incident. So it is good to put this idea in a trainee so that he starts seeing every case in all these things. So this is the 4P factor model. And the age-old diathesis stress model by Michal, where the person already has a diathesis, which can be biological or it can be psychological, which is happening for a long duration. And only when there is a stress acting upon the person, depending upon the amount of stress and the predisposition, if it is high, the chances of disorder getting manifested are high. So I personally feel the two-hit theory is kind of same old wine and new wine in the old bottle, because old wine in the new bottle, because this ideally we were reading about two-hit. Ideally, two-hit came in retinoblastoma research, where the sporadic form and the familial form. So sporadic form develop only in one eye, whereas the familial form can develop in two eyes, because to develop in bilateral eye, you need to have two separate genetic mutations. Whereas our theory, although we say two-hit theory, I feel it is a modification of what is already discussed. So because here we say the first hit is biological or genetic, the second can be a stress which we discuss here. It need not be a genetic modification, it need not be epigenetics. So the second thing can be some environmental factor which acts on the vulnerable brain and makes the patient produce the psychotic symptoms. So the risk of developing psychosis, when the ARMS studies, they have estimated, the initial estimates were quite higher, but of late they say only around 20 to 40%. Initially it was 50% in 2 years. But recent studies say it's not as high as that. Only 20 to 40% of people who have been identified with ultra high risk of psychosis develop psychosis in 2 to 4 years. So many don't develop. That's the factor we need to understand, because one pitfall of identifying at-risk patient and treating is unnecessarily exposing them to treatment and probably creating a anxiety or a taboo or a stigma in their minds. So when we educate also, we should say there is a 30% risk of developing, but still 70%. But ஒரு வெல் கண்ட்ரோல்டு ஸ்கிசோஃப்ரினிக்ஸ் பைபோலார் கேட்குற மாதிரி தான், கல்யாணம் பண்ணலாமா, எங்கள் பிள்ளைக்கு வருமா அப்படிங்கும்போது we say we are not able to say don't come. We give the data and say 1 out of so develops, 8% develops, so the rest 90 may not develop if they are stable. So similarly, we have to emphasize that only 30 to 40% develop and others you may not develop. It doesn't mean when you, just because we are saying you are at risk of psychosis or bipolar, doesn't mean you will definitely develop. There are high likely chances, but you may not develop also. And that's the problem with false positive rates. And as I said, pluripotentiality of outcomes. So at-risk persons can develop into any other disease also. It need not be the disease which we are focusing. So thereby then comes the cross-disciplinary approaches. It's not psychosis, it's not a mood disorder, So it's a cross-disciplinary approach which focuses on, in addition to transition to psychosis, long-term psychotic disorder, and persistent subthreshold psychotic symptoms, progression also to mood disorders, anxiety disorders, personality and substance use disorder, personality more so borderline, is also a common outcome. So therefore, the approaches could explain the pluripotent and transdiagnostic development and also the biobehavioral mechanisms. So various risk states which have been studied. The commonest which I was discussing is the ultra high risk, where you need to have the either attenuated symptoms, brief symptoms, along with the genetic vulnerability and the functional decline. So this is UHR, this is for psychosis. And ARMS, or at-risk mental state, this allows a broader understanding of mental health risk beyond psychosis. It goes not only predicting psychosis, we are also trying to focus on others. Another symptom which has been used in psychosis research is basic symptom approach, where the focus is on basic symptoms. Basic symptom is basically more of cognitive symptoms and also some perceptive abnormalities, rather than focusing more on, because the attenuated psychosis, subthreshold, these are all focusing again on positive psychotic symptoms alone, and not much of importance is given to negative symptoms. Whereas basic symptoms focuses on, it's more like Bloyler's 4A's, and the focus is more on negative symptoms also. And even bipolar people can be identified. So they are called bipolar at risk. And the basic research says early risk factors leads to various psychopathologies, not single psychopathology. Same factor can cause various disorders. So we need a cross-disciplinary approach. And there comes CHAMS, clinical high-risk mental state. It not only identify high risk, it also intercept low risk cases, including subthreshold symptoms of various disorders, not only psychosis. So if you see here, the progress of mental disorder starts from unspecific mental state, goes when it reaches a diagnostic threshold, we're able to make a diagnosis. So various environmental factors play here, make the individual vulnerable. Only with the vulnerable individual develops a syndrome. So here earlier the focus was on the ultra. The first episode, people developing a first episode is this circle, whereas the ultra was trying to capture a bigger circle. But the current focus is on clinical high risk mental state, which is even broader. So that we'll be able to identify people at a much earlier stage, even at the stage of microphenotype, before they develop functional impairment. This is the sequence they develop. Then they develop mild stress, finally leading to full threshold disorder. So the clinical high risk mental state tries to identify a broader spectrum of disorders with even lesser symptoms, and which could also include not only psychotic symptoms, even affective symptoms also. So there are various assessment tools and scales. There are n number of lists, but I'm just listing out a few. I'm not going into the details. So, but before everything comes a comprehensive clinical interview with collateral history. We do it with all patients. We get objective history from family members, and it should be comprehensive. Even with the clinical history, you will be able to identify prodromal factors also. So our age-old detail MSc whole school here. And CAA-RMS, unlike the CHAMS is CHA-RMS is a subgroup, whereas CA-RMS is a assessment scale. So this has 15 symptoms, including 4 to 5 thought symptoms, 2 symptoms including referential beliefs, and some thought disturbances and affective disturbances. This does not include much of negative symptoms. So CAMS is a good scale, comprehensive assessment of at risk. This has been used in many studies. And for Prodrome, there are 2 scales. One is structured interview of prodromal syndromes, and then there is a prod screen or a prodromal questionnaire. These 2 questionnaires are used in many studies. And other than the scales, we can use GAF or PANS and GAF, because most of the thing also requires a functional deterioration. So if you could document a reduction in global functioning, that also, or you could monitor whether the global functioning improves. And one particular scale which many researchers suggest is the early recognition inventory of the retrospective assessment of onset of schizophrenia. This scale, in addition to the CHAMS, CAMS, has also measures of negative symptoms and other affective symptoms. So these have been also used in various studies. So if you want to remember few, CARMS and ERI-ROS with the prodromal screen. So these are available. And now coming to the intervention. So we all need to identify, okay, prodrome risk irukku. So what do we do? So how do we intervene, and what is the evidence which shows interventions are beneficial? So one, we try to prevent the conversion to disorders, conversion or transition to psychosis, or conversion to any major disorder. And if that is not possible, at least reduce the deterioration of functional outcome. So these are our goals when we do trials in high-risk individuals. So most trials have focused on cognitive behavioral therapy, with a few also on antipsychotics and antidepressants. So basically CBT, basic things like psychoeducation, family interventions, social skills, and more for psychosis, metacognitive training, where they are able to address their appraisals about symptoms. So they have brief psychotic symptoms. So these are been done in most of the studies, and cognitive remediation when there are some cognitive deficits. So these are the various CBT interventions which have been tried. And pharmacological options, careful consideration of antipsychotics, low doses. There have been studies with risperidone, olanzapine, and omega-3 fatty acids, and even microbiota nowadays. So there are some studies, although there are not much of results, but tolerability may be an issue, good issue when you are able to use omega-3 fatty acids. And basically we should have staged intervention. So we should start with the benign or education, support, monitoring for low risk, and as the risk ascends, we should go up with higher risky situations like exposing antipsychotics to a developing brain. And more importantly, we should have regular monitoring and regular follow-up to assess whether they are improving and whether they're developing, transiting into disorders. So there are certain studies which have been done, or certain models which have focused on high-risk individuals. One such thing is PACE, study from Australia. It's a PACE group where they have done CBT with risperidone was compared with placebo, and they are saying there was a significant around 50% reduction in transition to psychosis compared to the placebo group, and this study said there was possible to delay development of psychosis. And the PRIME study from US was a double-blind RCT comparing olanzapine versus placebo. Here also, if you see, there is a 50% reduction, 16% with olanzapine compared to placebo at 1 year. So these were initial studies which showed very high, 50% chance was a very good reduction. And UK study, CBT and monitoring, both here there was no superiority, both monitoring and this reduced the transition rates. And intervention can reduce predicted transition by around 50% over the next 2 years. But the recent meta-analysis also says similarly, CBT reduces the risk of transition by around 50% at 12 to 18 month follow-up. So this is 6 to 12 month follow-up. If you see, these are various studies, and average around 0.4, 0.5 is the relative risk, reduction in relative risk. And the mean reduction was 64, was higher at 6 months, 64%, 50% are at 1 year, and around 30% at 2 to 4 year follow-up. And the number needed to treat is only 9 to 15. So to improve one person, you need to treat around 9 to 10. This is not a good NNT, but it's not very bad also. In fact, NNT for statins to prevent heart attacks were even higher. So the number needed to treat is quite impressive. And many studies have found out not only the symptoms we discussed earlier, depression and anxiety are also commonly seen in people with psychosis. So they are also necessary conditions for the onset of psychosis. So here the advantages of simple and basic interventions which could improve depression and anxiety could help us in improving the functional outcomes. So basic things like behavioral activation for depression, short-term CBT, interpersonal therapy, low-dose antidepressant anxiolytics. So, and even a focus on how clients appraise the experiences and how they regulate the effect. So, basic coping strategies, stress management techniques, which also can be taught to a public at large, could also be powerful method of reducing distress. If not transition, at least the distress of the symptoms can be reduced, and they can have, most studies have, recent meta-analysis have not shown as high a reduction which was shown earlier, but they say the patient's distress after developing psychiatric syndrome is definitely lesser if they are exposed to these kind of therapies. So, a slide about at risk for bipolar, because in bipolar, most of the studies have identified only after a first episode has happened. So, they have not caught in prodromal stage. So, one thing we already use is questioning for bipolarity in patients with depression. So, probably a patient comes with depression, we don't know whether it's a single episode of depression, RDD, or bipolar. So, we use scales like bipolarity index to identify the higher risk of developing manic episodes. So, therefore, here the evolution and characters of the subthreshold manifestations are usually constructed retrospectively, or the research focuses on this to research on the offsprings. So, patients with bipolar disorders, if you could study their offsprings and take them as at-risk individuals. So, this is one approach which have been tried. And generally, in other things, we are in bipolar, we try to identify the illness trajectory, how they will develop episode, how frequently they develop, and their paradoxical responses to treatment. So, here also at-risk states research helps in identifying early signs of relapse. We call it relapse signatures, right? So, early warning signs of relapse, potential triggering events. In fact, one study found out many patients are able to identify these symptoms before they develop a mood episode. In fact, if I remember one patient when my PG time, I think his name is Janaki Reddy. So, he had 4 or 5 episodes in the past, admitted in CMC Vellore, underwent good treatment, but never followed up even once. Because he was coming from Andhra. So, when I was seeing I think I was a lecturer, first year lecturer, I was for handling his case. So, that time I spent quite some time with him. So, that's the only thing I did with him. So, a few months after an episode, he was on therapy, he was coming early, he was working as a journalist at the Hindu. So, he suddenly called me at 5:30 in the morning to my intercom in my house, which usually I don't give. And then I said, sir, I'm feeling happy for the past 3-4 days. I'm doing a lot of exercises. I've written 2-3 editorials. But you have told me if these kind of things happen, it could be a mania. So I doubt whether it is mania. Should I increase my medicines? So I was happy. Okay, I did some work to somebody and just called him up. And when I went to the department, starting from the director, not of psychiatry, CMC director, CME, MS, ellarum, hey, yaarpa and the Nirmal. And a whole night he tried calling me and he was not able to reach me. He called the principal, he called the MS, எல்லாம் கேட்டு இந்த நிர்மல் காலையில் போனால் எனக்கு அப்படியே ஒரு ஆச்சரியம். ஸோ சிமிலர் டைம் another patient I was treating him when I was getting that day I took off for my engagement. He was asking discharge every day. ஸோ என்கேஜ்மெண்ட் லீவ் போட்டு வந்துட்டு அடுத்த நாள் வந்து செம்ம கோவமாக இருந்தான். ஏன் டிஸ்சார்ஜ் பண்ணலன்னா நேற்று என்கேஜ்மெண்ட் போயிட்டேன் ஏதோ சம்திங் செட் அது ஒரு கெட்ட வார்த்தை சொல்லி இதுக்கெலாம் நான் வெயிட் பண்ணுவாடா அப்படின்னா ஃபைன் ஓகே சரி நம்ம தொழில். But a month later or 2-3 months later when I went to my honeymoon, I get a call from him. And he was from, I think, Krishnagiri தான் சார். So he called me up and said, சார் ஒரு 4 நாளாக கொஞ்சம் வேகமாக இருக்கேன், ரெஸ்பிரிடோன் ஏற்றிக்கிட்டுமா அப்படின்னா சரிப்பா ஓகே வந்து பார்க்குறேன் நான் வேறு வேலையாக வந்திருக்கேன் கொடைக்கானலுக்கு. So why I'm stressing here is, even patients are sometimes able to identify their early signature symptoms. இன்னொரு பிஸ்கட் மணின்னு ஒருத்தர் சொல்லுவாங்க சிஎம்சியில். ஏன்னா அவருக்கு ப்ராப்ளம் வந்தால் அவர் டின்னாக பிஸ்கட் வாங்கி நாய்க்கு போட ஆரம்பிப்பார். ஸோ அவர் பர்ச்சேஸ் பண்ணாலே கிராமமே சொல்லிவிடும் பிஸ்கட் மணி வந்துட்டாயா. ஸோ லைக் தட். ஸோ வி வில் பி ஏபிள் டு ப்ரிடிக்ட் certain things, and in bipolar, although we are not able to prevent the onset of the disease, we will be able to reduce the severity of the episodes and probably அண்ட் அந்த டெம்பரல் சீக்வன்ஸும் மெனி பேஷண்ட்ஸில் போட்டிங்கன்னா தெரியும். இந்த ஃபஸ்ட்டு சிம்டம் இதுவாக இருக்கும், செகண்ட் இதுவாக இருக்கும். ஐ வாண்ட் டு டிஸ்பிளே, ஐ forgot it. ஒரு அந்த வி ஆல் நோ there are what to say, there are tabular columns which you can to monitor moods, to monitor early warning signs. ஸோ அதை வந்து நம்ம பேஷண்ட் சைடில் எழுதி நம்ம கேஸ் ஷீட்டில் எழுதி வச்சு ஒரு காப்பி அவங்களுக்கும் கொடுத்துட்டா இட் வில் பி யூஸ்ஃபுல். ஏன்னா சம்டைம்ஸ் the patient is not agreeing whereas the family wants to bring, it's a huge clash and difficulty. So if you could work it out prior to during your regular consults, it will help in a long way. So now the focus, as I was saying, was on multidisciplinary and trans-diagnostic models rather than on one particular disease. So one is clinical staging model, which is like cancers. In cancers, you stage the disease, and depending upon the stage of the cancer, your interventions change. So similarly, even in psychiatry, we are asked to address the need depending on the different stage along the continuum from health to disease, and addressing mental illness before they escalate. So main focus is on prevention and early intervention, more so in youth. But current medical services, even in the Western countries, are not adequate for youth mental health, and significant delay in treatment for the youth, probably due to stigma and inadequate service delivery systems. So the youth mental health intervention, why we need to target is, it is a neurodevelopmental change. So it poses not only vulnerability, it also provides us an opportunity to improve the plastic brain. And for an adolescent, meeting physical, psychological and social need is essential for optical brain development and emotional regulation. And adverse experiences, we all know, leads to long-term negative outcomes, not only in psychosocial, also in academic and occupational work. And the secure attachment relationship and having a good family to care is a healthy emotional and behavioral response, and these are protective factors. And interventions focusing on multiple problems, not on single disorders, are shown to be more effective. So one is mental health promotion. So here at the population level, when we improve mental health literacy, when you promote mental health, the individual and community develop resources to improve their own mental health control. And meta-analysis also point out that youth prevention reduce psychosocial difficulties, and multimodal programs have long-term benefits, but they should combine both preschool intervention, school, and also the family support, and to be tailored to the individual and tailored to the socio-cultural context. We cannot just use the Western models here. And coming to our 4 levels of prevention, I'll finish these things faster. So primary prevention is focused on the universal, focus more on non-risk patients. So you are using universal prevention aims to promote normal development by, for example, home delivery, hospital delivery, baby care, you foster proper neurodevelopment. And selective prevention is identifying at-risk people, either with family history or other things, and address the shared risk factors. Indicated prevention is for individuals who started showing mild signs of mental issues, and here you try to alter the developmental trajectory. Rather than letting it develop into a disorder, you try to reduce it. So early interventions can reduce the risk of developing full-blown disorders. Secondary prevention, the disease is already set in, you focus, try to recover him fast, and try to mitigate the negative prognostic factors. இப்போ ஏதாவது சப்ஸ்டன்ஸ் யூஸ் இருக்குது, இல்லை வேறு ஏதாவது இஷ்யூஸ் இருக்குது, எஜுகேஷ்னல் ஆக்குபேஷனலாக ஒர்க் இல்லை. ஸோ யூ ட்ரை டு மேக் தோஸ் ப்ரொக்னோஸ்டிக் ஃபேக்டர்ஸ் reduce the negative and make it positive. And collaborative care models, where rather than referring to so and so doctor or they referring to us, if you could do it as a collaboration, this can have better. Tertiary prevention is addressing resistance. Treatment vandirchu, disease vandirchu, try to handle resistance and try to prevent relapses and progression of the disease. So we need to have validated interventions to prevent multiple relapses and chronicity. So to put it another way, so here if you see, starting from pregnancy to young adulthood, prenatal, these environmental risk factors, there are already prenatal and perinatal events. And then the critical period is of neuropsychological development, where problems related to attachment, neglect, trauma, and the stress response, these could affect the brain when it is at the most rapid growing stage. And as they progress, if the risk is less, they develop mild at-risk syndromes or attenuated symptoms. When the risk increases, they develop a full-blown episode. So here, at this stages, you have universal and selective prevention where you guide it throughout the population. As they progress horizontally, we start giving more selective prevention and early intervention. And there should be a continuity of here. But if you see both, these can not only lead to one type of disorder, both for internalizing disorder and externalizing. So it is a trans diagnostic, and finally, if unleft, they can develop into a full-blown episode. So here you can intervene at various levels. So early interventions, I have expanded, as I said, from psychotic to include other disorders, and there are certain programs which have been successful in doing this. One such thing is, as I said, the PACE Australia has one, and then Massachusetts Child Psychiatry Access Project and Health Services Program for Youth. Australia's Headspace is quite popular. You would have come across this. They started with 10 centers. Now they have more than 100 centers catering more than 10,000 youth. So these studies have shown reduction in social ideation, self-harm, and absenteeism from school or work. And similar things from other countries, Headstrong and Jigsaw in Ireland, Youth Space in UK, Access in Canada, and the Foundry and At Ease in Netherlands. So most countries have developed interventional models to handle youth, and they try to intervene early. So there are certain common elements which have been found from these studies, which are needed to, if you want to implement a model. One, the model should be highly accessible, affordable, convenient, timely. It should not be stigmatizing, flexible, include everybody, and it should promote awareness on the whole. And it should be acceptable to the youth, confidential, youth friendly. They should be respected and engaging, and it should be a collaborative model. And appropriate is early intervention focused, comprehensive. It should be developmentally appropriate and suitable to the early stage and the complexity, and it should be evidence based and quality assured, and it should be sustainable. So to do it sustainable, we'll have to integrate with the existing primary care models. So psychiatry, DMHP, we should do it along with the primary care, and it should be community embedded, integrated within a national framework, effectively managed, and it should advocate for well-being. So this was the model, staging model I was discussing. So here if you see stage 0 is asymptomatic to distress disorder, then first episode, recurrence and persistence and treatment resistance. Earlier this was, I didn't put the picture, it was a single peer, dropping peer where this alone was there. So it was people with less, one disease alone, they had multiple factors, all these are different symptoms, they finally lead into psychotic. But now research says no. So for color, each color you can see. So people can have various disorders, and they can manifest as either depressive, bipolar, or personality. So if you, at this stage, if you handle, if you before the macro phenotypes manifest or the first episode, our intervention could prevent most of these disorders also. And future innovations, one, as I said, the other pharmacological agents like amisulpride, aripiprazole, some antidepressants, lithium, benign drug agents like glycine, microbia, D-cycloserine, and innovative psychosocial interventions like mobile technologies, social networking, exercise-based remediation, and feedback video games, and also additional targets like inflammation, brain development, engaging and motivation, and more importantly, as adaptations of supported employment. Most of our people with schizophrenia have difficulties in social skills and getting into employment. So giving them proper employment, education, skill building, and cognitive remediation. These are innovations which are being under investigated. And the last slide. So what do you think are the challenges or disadvantages of intervening earlier? Only 2 more slides. You mean by medication, side effects of medications or the cost? They wouldn't reach at the earliest. Many people have type stigma, I think. Don't want to accept at risk, you're right. That itself is a stigma. Okay, sorry. This is unintentional. So, as you rightly said, most of the challenges you have read, we'll have to be careful not to over-pathologize. Because many youth, nowadays we see, இப்போ நம்ம clients வரவங்க எல்லாம் இந்த கோவிடுக்கு முன்னாடி கோவிடுக்கு பின்னாடி many adolescents have brought saying COVID, staying at home, online. So, a lot of way how parents perceive or children handling parents is very different. So, many of this could be normal. They need not be affective or psychotic disorders. So, many times this can lead to unnecessary anxiety in the individual, which could lead to self-stigmatization or stigma from others. And we get a sense of vulnerability or fear. And this could also impact well-being. And generally, as I said, adolescents can have a natural ebb and flow of both psychotic experiences and affective symptoms. So it is difficult to predict whether they'll develop any disorder, if so, psychosis or affective disorder. And balancing early treatment with, we should be we should foster autonomy and confidentiality to be maintained. And as we earlier mentioned, limited predicted validity of prodromal markers, side effects of medication, and it should be culturally adapted into early interventional models. But still, the points which support favoring an intervention is that people who develop clinically high-risk patients already have distress and stigmatization because they were referred. These most patients who are at risk were referred because of their mental problems. And they have hopelessness, depression, anxiety, and poor QOL because of this, exhibit poor coping skills, low self-efficacy. And they also have social and neurocognitive deficits, some impairment in outcome, negative symptoms, and there are certain abnormalities in functional, structural neuroimaging, electrophysiological neurochemistry, even prior to onset of the full-blown episode. So, we are not only preventing and treating a future problem, people who have mild symptom also are seen different by the society. They already go through these deficits. So, we are justified in intervening. Probably we should use the more low risk events to start off, and then probably, depending upon it, go up to do. So what to do, how to do, when to do is one. We should, as I said, we should potentiate the social management of at-risk conditions, but we should not medicalize serious problems. So it is a balance we take between benefits of early detection and potential for misdiagnosis and serious problem. How to do? Our clinicians should be trained to recognize prodrome without jumping to conclusions. So I remember one of my UG students in Vellore, in Bhubaneswar, she's a child psychiatrist now. So she came once saying that my brother is in 12th, sir, or 12 1 year, he's not talking. He feels talking is waste of time and is saving energy to prepare for the 12th. So immediately she attended my class in psychosis. She thought her brother might be going into psychosis. I said, you bring him for a consult and we'll see. But it didn't come actually. And years later, I called her up, I talked to him, and we met on social media. I asked, how is he doing? What is he doing? Sir, he finished his engineering in IIT, sir. He was working in Reliance and he's married. No problem, sir. Happy. So, we should not jump into conclusion based on what we hear. And it is how we communicate. So, we should mitigate the fears. We should not just create a fear. You are at risk, man. So, we should mitigate saying that you will not definitely develop it. There are chances, and even if you develop, there are effective interventions to treat, and we should promote collaborative approach for treatment. So finally, prodrome and risk states should be seen as an opportunity for intervention, for prevention, and at-risk mental states is a bridge between risk and resilience. And early detection requires multidisciplinary vigilance. It should be timely, compassionate care, which can change trajectories of disorders if not prevented. And regular follow-up and monitoring can help adjusting the treatment plan according to the need. and using standardized tools, not only psychopathology tools to diagnose diseases, the at-risk scales which I said, or prodrome scales, will help in identifying these states and monitor them more reliably. And comprehensive assessment and personalized care plans. And as mental health professionals, இப்போ நம்ம பார்த்த universal precautions directly not in our hands. But we know as an body, IPS has done many changes in things. For example, decriminalization of suicide இருக்கட்டும், இப்போ நம்ம teen immense issue வந்தப்போ நம்ம பண்ணது. So we are able to do some changes at those levels. So as a psychiatrist or mental professional, we have the scientific moral responsibility to guide social and political bodies in addressing youth mental health. And youth mental care should incorporate prevention and early intervention strategies, collaboration with families and multidisciplinary teams, and the early intervention should be sustained across all stages, including preclinical phases. And we need to have ongoing research and education to refine diagnostic criteria and treatment approaches. Thank you. So early recognition today prevents illness tomorrow. Thanks for the opportunity.
Thank you, Dr. Nirmal. It's a very, very tough condition. It's not a tough topic. It is a tough condition. Actually, everyone experiences when trying to tackle psychiatric illnesses. And my point here is many of the things you have highlighted very promptly and effectively, particularly about over-diagnosing or branding them or making the stigma more worse for the family members. And sometimes they may go away from us. They go for some other treatment methods. That's also a risk. And my take here is prodromes can be easily diagnosed in certain conditions, particularly in twins. If one of the twin is affected, and during the mostly the identical twins. Nowadays we are seeing a lot of twins following this IVF under the artificial things. We can clearly say the twin will have, because the risk is more. In those conditions we can be bold, but in other conditions it is very difficult to say that the patient will have an illness, so we can terminate or prevent by giving drugs. That's a very, very, very difficult thing, or a difficult decision, or we cannot take any decision, because any decision we take will not be considered as ethical. We consider something as ethical, and the patient's family members will say it, or the society will say it as unethical. How, before you say, are you God? How are you going to predict? How will it be? As he said, he's one of his pediatric colleague, pediatric psychiatrist's brother, coming in high colors after 1 year, saving all his energy and getting completing his IIT. Similar things happen. One more difficult situation for me is a patient totally on remission, completely following for years together with minimal drugs, and suddenly, I am meaning about a bipolar individual. A bipolar individual, probably schizoaffective, because she was telling me that she was hearing voices and she was on very minimal amisulpride. And for 4-5 years, she was only on 50 milligram amisulpride, and she used to phone to me and talk from Chennai and say that she is comfortable looking after the children, looking after the household course. And after 5 years, her husband and father brought her, telling the complaint that she started spending online through his husband's mobile. And when I asked, is this new thing for you? She said she was very happy. She was in hypomania. So this can be considered as a prodrome, which was not diagnosed by the family members and also by me, because whenever she communicated by phone, so she said she was normal, she is very comfortable, she wants to take only that amisulpride. And when I started on mood stabilizers, she said, "Enna sir, drug kutringa." So we may be also missing, unless otherwise the standard measuring tool for a prodrome is very concrete and constructive. But we use tentative schedules only, or tentative scales only. That's the thing here. So many would have come across these situations. And my question, what about any mention about twin studies regarding prodromes? Because the risk is more, definitely, when compared to the other population.
They looked into offspring, sir, but twins I didn't come across, sir.
Sometimes many patients are intelligent. The grandmother will say, "Sir, என் பையனுக்கு இதே வயசில் வந்துச்சு சார், இவன் அதே மாதிரி செய்கிறான் சார், grandson. So I suspect, I doubt, அதை வராமல் தடுக்க முடியுமா சார், ஏதாவது மாத்திரை கொடுங்க." What shall we decide? When the patient is, when you examine and he himself is totally free of symptoms, how to convince? So there are a lot of difficult situations the psychiatrists will face. So with these few words, I hand over the session.
Any questions from the floor? You want some questions from the floor?
Yes. Thanks. It was a very lucid presentation. In fact, you made your presentation interactive. That was nice. And thanks to the organizers for selecting this particular topic. Whether it is related to practitioners area, I think this is more important for practitioners because they need to go for outreach camps where we can identify these kind of problems. Usually the attenuated symptoms, the blips or the prodromes, they won't reach us that early. In fact, in our culture where stigma is still prevailing, people come here very late, in fact after doing all the magico-religious treatments. So this topic is more relevant for us, why we need to participate in IMA camps or other programs. You mentioned about the Headspace program. In fact, Mohan Isaac sir, Professor Mohan Isaac, who had worked in Nimmans and moved to Australia, he had discussed about this with me. In fact, this program is all about going and meeting youth and talk to them, listen to them. And finally, they pick up these prodromes and attenuated symptoms and subsequently refer them. Not for medical therapy, as you rightly said, a stress thesis model and biopsychosocial risk factors identification. With that, they pick up the people who had that early symptoms and subsequently recruit them to treatment programs. What he had said is, it is it requires two budgetary allocation and it is very difficult to run that program. Even in Chennai, SCAR, Dr. Sivaprakash is running this program. He runs a monthly once or twice youth fund program. He don't organize it or call it a medical camps or mental health camps. He call it a youth program, a movie program for youth. He calls in people from colleges and talk to them, sensitize them about at-risk state and help them to reach clinics. So this is a very important topic and we cannot look at it as a clinician doing it from clinic, but rather clinician to reach for outreach camps or programs where he does things along with others as he works like a psychiatrist. Thank you. It's a good topic, good presentation.
Thank you, sir.
So, excellent talk. Congrats. And if we treat in the prodromal state, before the symptoms develop and all, are we legally protected? Because MHC has become a very big headache. So in what way we are protected? Because somebody should not claim that I was only anxious, they put antipsychotics. So such an issue should not come in future also. As soon as Kannan came, I thought of legal issues, please.
Excellent presentation, Nirmal. Basically, prodrome is a retrospective concept. Prodrome begins way before actual psychosis starts. Almost 1 to 5 years it takes to develop psychosis. The questionnaires and scales that you have shown are often used to figure out, prodromal or at risk, the symptoms, இது இருக்கலாம் அது இருக்கலாம் அப்படின்னு retrospective தான் we are going, and diagnosing it. So there are flaws in it because we dwell on the family members' memory whenever we administer these scales. So it is getting biased too. So we do not know what are the symptoms which predispose them to develop actually psychosis. In that sense, some of the prospective studies have shown that the externalizing disorders or in some of the internalizing disorders are found converting into psychosis later. But here also a subpopulation only develops it. May not be able to clearly say this disruptive behavior is getting converted into a psychotic case later. So in that sense, some of them developing bipolarity, schizophrenia, some of them have borderline PD, but they remain as a PD forever also. So what we need to do is that prospective studies need to be done, follow-up studies needs to be done, which will give us a clue that what are the symptoms which can predispose individuals to develop psychosis. So we need to start from the preschool level, as you mentioned. Probably child psychiatrists would take up and do it effectively, like Dr. Preeti and Bhagashri should initiate it, but easily said than done. Very difficult to do it from the preschool level. So no studies are available in India to say that, these are the studies which are there on the prodromal side.
So, but some of the studies have used prospectively, sir. At-risk studies, the CRMS, UHR criteria, they are prospective studies. The meta-analysis and all are prospective. The prodromal studies, are retrospective. And as you rightly said, they are not only targeting clinical samples, headspace sir sonamari school children, and the it should, along with other associations and school interventions, we should probably the Manam program which we have in our medical colleges now, although it is different from here, but we should have similar kind of programs at various school level where you do not expect even mental health persons to intervene. It could be even counselors, teachers who could identify, and then it will be a series of a process of referral. So that is when we will be able to implement, because although it may sound, as sir said, they find it is a huge budget, but the honest, but the improvement you get when you handle it earlier should be gratifying, and that should take us more interest and develop similar studies in India. Thank you, sir.
Ganesh, one word. This adolescence and childhood development, I clearly remember when I was a student, I used to read CTB5. It has given all the psychiatric symptoms in the adolescent phase, and it will say, finally it will resolve. So you need not diagnose, or you need not have an idea that all will go for psychiatric disorders. So one should be very watchful. That's our over enthusiasm should not stigmatize them. That's a very clear indication. Adolescent turmoil and all other things will look like prodrome, but we should not be judgmental that we should not conclude that it is a illness. So that in that area also it's very difficult. So in adults, probably in adults, grown-up adults, we can be concerned about the prodrome, but not in adolescents. It's a very difficult situation as well as a difficult condition for us and for the individual also. So we have to be very watchful.
So we are running out of time. I think it is quite challenging, as he said, to diagnose at risk as well as prodrome. The second thing is whether to treat or that is how we have to go about it. But you'll have to have that is eagle's eye and then a lion's heart actually to treat this condition rather than anything else, because sometimes they don't accept it. In spite of that, when they seek help, we'll have to give them, and we'll have to follow them up so that they don't develop, that is, psychotic conditions or some syndromes later, that we can prevent at least some of them. That is the thing, the take-home message. So with that, we conclude this session. I thank the opportunities for giving me, I thank the organizers for giving me this opportunity for chairing this session, and also the speaker.
Thank you.
A good one.
Thank you, sir, for your interactive presentation. Now we request our chairpersons to honor our speaker.
Now we request Dr. Arun Kumar sir, Secretary IPS TN Chapter, to honor Dr. Kumanan sir.
Now we request Dr. Paneer Selvam sir, Senior Consultant Psychiatrist, to honor Dr. Sabita ma'am.
Thank you, sirs and ma'am. Let's have a short tea break and assemble back within 15 minutes. Let's all assemble back within 10 minutes. Thank you.
With the next session, we are going to start with the next topic, AI in psychiatry, clinical scribe, tools and emerging trends. I request everyone to please assemble inside the hall to start the next session. To start, I request everyone to kindly assemble inside the hall to start with the next session.
Now let's start our second session, AI in psychiatry, clinical scribe, tools and emergency trends.
Let's invite our respectable chairpersons, Dr. Paneer Selvam sir, Senior Consultant Psychiatrist, Snega Mind Care Hospital, Trinelveli.
And Dr. Vishwanathan, sir, Associate Professor and Head of the Department in charge, Tirupur Medical College.
Let's invite our speaker, Dr. Janaki Rajagopalan Madam, Consultant Psychiatrist, Chennai.
Good morning to all. We are going to start an next session, AI and psychiatry. We all know that artificial intelligence become an integral part of our day-to-day life. You start with a phone. If you, for example, you start with a smartphone. The smartphone will, when your heartbeat rises, the smartphone will indicate that you are stressed. You do relax and ask you to do breathing exercise. Similarly, when you look at the Netflix, it tell you suggest what film you have to see. So there are many things as AI will have play in your day-to-day life. and especially in psychiatry. Psychiatry, I think AI cannot be separated in psychiatry. It's going to play a very, very major role in psychiatry. Especially, at present we are using it in medical recording. Electronic medical record, fully we are been utilizing this AI only. So gradually we are coming off writing gradual reduce. Nowadays the AI has come in such a way, helping in such a way that if you are talking to the patient and it record the conversation in text mode, that way it helps a lot. Actually, when you see the patient, it takes at least 10 to 20 minutes on recording the patient's history. When you talking to the patients, when you are focusing on recording, we cannot make an eye-to-eye contact. But when the AI started recording our conversation in text mode, it helps doctors, especially psychiatrists, a great thing. And also AI is helping psychiatrists in a many way. Like AI has come with many tools in implementation also. Implementation tools like CBT and many things have been done by AI. AI have a lot of advantages. In addition, it have a negative advantages also. I think that Dr. Janaki Rajagopalan will enlighten us what is the importance of AI in psychiatry, regarding the scope in scribe tools also and emerging trends in AI. So our co-chair will introduce our speaker. After that, you can have your presentation will be at 40 minutes. So we have the inauguration at 12. So that you take 40 minutes. After that, you can have some questions. My co-chair will introduce the chairperson.
Our prestigious speaker, Mrs. Dr. Janaki Rajagopalan, qualified as MBBS and MD Psychiatry at Delhi. And she has 15 years of experience in the field of psychiatry. And she had many credit in her head. And the area of interest is depression and other anxiety disorders, schizophrenia and other psychotic symptoms, and psychotherapy, marital therapy, and interpersonal therapy. Thank you. And over to the...
Okay. Good morning, everyone. I thank the Tamil Nadu IPS and the August gathering here for giving me an opportunity to present today. I would like to especially thank Sadanand sir, who helped me throughout to prepare the presentation as well and gave me tips. So as Paneerselvam sir already said, that we use AI in every aspect. But the thing is that sometimes we don't acknowledge that we're actually using AI. And sometimes we have some kind of resistance as to what will happen with the use of AI. Many people believe that AI may actually replace us, that as doctors, it may become more important than us. Some people believe that AI will be very negative and influence the patients. So today, I'll try to talk through all these concerns and also talk about some of the uses of AI in psychiatry and for clinicians, especially for clinicians. So let's start with the objectives for today. So today we'll try to identify the key tools in AI for diagnosis, transcription, therapy, and monitoring. We'll also try to evaluate the evidence base and limitations for AI in psychiatry. Then we'll try to integrate the AI safely with appropriate ethics and governance. We'll plan a pilot implementation in your clinical setting in a day-to-day life so that you can use it when you go out from here. And we'll also try to tell you the use of AI for research, writing, and academic presentations while maintaining the ethical standards. So we're a small gathering here, and unlike the previous presenter, Dr. Nirmal used some technology, but what I'll do is I'll ask you to raise your hands. Okay, when I read this out, please raise your hands for what you think you're doing with AI in your practice. So raise your hands if you're already using AI in your clinical work. Wow. Okay, few people are. Then the second one is no, I haven't incorporated AI in my practice yet. Okay, right. Then we have planning to, I'm evaluating or preparing to use AI. Okay, so there are a few people who are eager to use, so that this may be really useful for them, this presentation. And then there's the last group which I find interesting because not sure, I may be using AI-powered features, but unknowingly. So we do use, okay. There are a few people who are owning up to that as well. So I just wanted to put this timeline. Of course, we know all this, right? I just wanted to emphasize how, like ECT, lithium, chlorpromazine, DSM, etc., was a revolution in psychiatry. It added to psychiatry. It added to the value of psychiatry. That's how AI and computational psychiatry is going to be for us in the future. So 2020s is going to be the decade or maybe the era of change of psychiatry. So just for clinicians, let's talk about what is AI. So we hear artificial intelligence all the time. So what is different? So let's say if I'm using Google, and we do go to Google directly, isn't it? What is the difference between Google and Gemini or any other AI? So AI are systems which perform tasks which require human intelligence. So the second thing about that would be, what is that? What is it that requires human intelligence? It means that it is something that is not a predetermined task, that it doesn't have any kind of predetermined set boundaries. So it can continue learning. So that's where the second concept comes up, machine learning. So it learns patterns from data, both supervised and unsupervised, and it grows. So that's the fascinating part of AI. It tends to grow with all the knowledge that you give it. So it also grows with knowledge from other places and it puts it all together. Then NLP, the natural language processing. Natural language processing means that it understands and generates human language. So this is the most important part for psychiatry. So when we're talking about transcription tools and all that, how does AI grasp the tone? It can actually grasp the tone of the person sitting in front of us. That is because it is able to do natural language processing. And of course, it has deep learning. So unlike any other forms of, like maybe Microsoft Word or anything, it has deep neural networks, just like a human being, just like a small child. So it starts learning things because of those deep neural networks. So when we think about AI, like if a patient comes to us and repeatedly says the same things, I went into this relationship, something happened, I had a breakup, then we are very sorry and we feel empathic the first time. The next time the same patient comes and tells us, I went into this relationship, I did this, and then we become a little bit upset with that person. We get a little bit biased. Oh, this person is troublesome. We feel that way because of our human biases. Next time the person comes, we say, oh God, this person has no, like, ideda manindrukno, tirpi, ide vishayandana. But AI will never do that. AI will always listen the same way. First time it will say, oh, I'm so sorry this happened to you. Let's look at something to do about it. The second time you come, same thing. So it will be consistent. So AI is able to listen endlessly, but it does not have the emotional skills that a human has. Now, this is very, very simple. Please forgive me. I'm not trying to, trying to be too oversmart. But can we have a raise of hands? Who thinks that ChatGPT is an AI? And who thinks that Excel is an AI? And who thinks that DALI and Visa are AIs? So here we know that Excel is not an AI. So this was for the discussion that Excel also has formulas. You can also use Excel to, calculate things. So what is different about it? It doesn't learn. That's the main thing. It has boundaries. It can only do some calculations. It cannot do all calculations. Whereas you throw the same thing at a ChatGPT, it will do the calculation. It will say, hello, do you want something else from me? Shall I give you another output? Shall I put another kind of bar graph for you? So that is what ChatGPT or any other AI can do. Now, why do we need AI? I think Nirmal sir really beautifully brought up all the gap that we have in treating patients. So we know that every psychiatrist here treats way more patients than they should. Like the norms, there is nothing, like in India, we cannot follow norms because every psychiatrist has to treat more than 20, 30 patients a day minimum. I'm sure the seniors here must be treating way more than that. And ma'am, I think Sabita ma'am must be treating in hundreds. So it is very difficult for us to put a tab on the number of patients we are seeing because the number of psychiatrists are so low. We are less than 1 per 1 lakh in population. So then what do we do? What can we do? Should we produce more psychiatrists? Yes, that is a possibility. But then where will we get the infrastructure? So that's where AI comes in. So AI can help with 40% decrease in documentation. It can help in trying to improving access, accuracy, efficiency, and enhance patient care. Now, what are the things that we can do? I'll be talking a little bit in detail about all of these, but the main things that AI can do can be divided into a few categories. So there is diagnostic triage, transcription and scribes, therapy chatbots, monitoring wearables, and EMR and clinic operations. And of course, there is the research work, which I have kept separately. Now let's talk about limbic axis, which is a behavioral intervention AI. So it is a diagnostic AI which was formed only for mental health. So what does it do? It allows for conversational intake, just like if you make a resident sit outside, I don't know, outside or inside. It's been a long time since I had residents. So if you have a person sitting with you and doing the basic, intake, maybe a nurse, maybe a CNC, maybe a social worker, maybe a psychologist, then they will do a triage. They will do a full history. They will tell you the symptoms, and they will tell you whether this patient needs to be seen urgently or not. Then they will present to the seniors, and they will get a management plan. Right? That's how we do things, isn't it? This is exactly what limbic axis does. So limbic axis listens to the patient, forms all the symptoms, symptomatology, brings all the symptomatology, and forms a diagnosis and a management plan. It also forms a risk assessment plan. But it does not take any further decisions. It will not send those things to the patient. So it is only for clinical care. As of now, it is not directed towards patients, but only for clinicians. And it has been approved by the NHS. Of course, by the NHS, because their waiting lines are like 18 months and all that. They do need something like this to decrease their queues. So what all can we use it in? It can be used in waiting list triage and prioritization. It can also be used for a structured referral pathway. So for example, a patient comes to you. They don't need a psychiatrist. They need a psychologist or a social worker. So it will automatically tell, this is not for a psychiatrist. This is for a social worker or a psychologist. Similarly, it can do standardized data collection for clinical research. So all of us are clinicians here. How many of us are able to collect data for research? We try to do our best for treating patients. We don't do any research work on a day-to-day basis. We try, some of us are academic, they do some research work, but clinicians are losing out on really valuable data because we're not able to do it on a day-to-day basis. So the limbic axis can actually form protocols and can separate clinical research work while doing its basic clinical duties as well. So unlike a resident, it will not make faces. It will not tell you, oh, I'm sorry, I can't do this. It will just do its work. And it will also give you pre-appointment intake efficiency. And we have an evidence base to it. It says that about 92% in validation studies, it comes up to the level of a clinician assessment. Second is that it reduces 60 to 75% of intake time. And it also shows high patient acceptance rates. So we usually think that, telemedicine or AI, etc. will not be acceptable by our patients, especially because, they don't like that kind of interface. They want the human empathy. But in global studies, of course, there is no Indian data on this. In global studies, it seems that this has been really, really well accepted by patients. But there are some risks and cautions. And we always hear about this, that there can be false positives and false negatives. False positives, still okay. But false negatives, that's a big problem. What if we miss some suicidal risk? What if some harm comes to the patient? And second is data governance. This is a constant problem across all AIs, that there could be a security breach. This could lead to some legal consequences. So we have to be aware of that. Now, in terms of diagnostics tools, like Kintsugi voice, we talked about limbic axis, which is an mainly intake and diagnostic tool. Kintsugi voice is an amazing kind of AI, which can listen to the patient only for 60 seconds. And it forms some kind of, analysis based on what it has heard with several samples, and it can tell you whether the patient is worsening or not. So every week, the Kintsugi voice, if the device is set that it will review with the patient every week, it just has to talk to the patient or listen to the patient for 2 to 3 minutes. And it will give you an idea of whether the patient is deteriorating or not, based on the kind of gaps the patient is giving in his speech, whether the prosody and tone are the same or not. Based on that, it is able to give you the deterioration. So there was peer-reviewed studies have shown that the area under the curve is 0.8 to 0.9, which is very high for clinical depression, and this study was done in 2024. And there is research that demonstrates consistent performance across all demographic groups. This was very important because there is always a demographic bias based on Western data compared to Eastern data, adults compared to children, old age people, but this was showing that it was the same across all groups. Now, in terms of this one was very interesting because it goes in line with Dr. Nirmal's talk about the prodrome. So we talked about recognizing the prodrome. And in this Winterlight Labs, it can detect any kind of change in cognitive capacity almost 6 to 18 months before it actually comes in tests. So we are all, we try our best, we give them questionnaires, we try to make them understand, that they have to fill the questionnaires. How many of our patients actually fill questionnaires? Mostly, they are not able to follow up with the questionnaires. So this can actually just, again, listen to the patient and give us an idea of whether their acoustic, based on the samples that it has taken already in the mass, in the general population. It's more than 5,000 samples it has taken. So it uses that to detect early signs of cognitive decline. So the sensitivity is 82 to 89% for detecting mild cognitive impairment in control studies. And it also shows that, as I said, 6 to 18 months before conventional assessments, it is able to tell us about MCI. So we can try to arrest the progression of MCI into dementia. Again, the considerations are external validity. So performance may vary across different populations, and there are no studies yet on Indian populations. Second is the real world drift, and this is a very important concept because we think that once we've made something, it's set in stone. But it's not like that with AI. AI learns, and then after that, like a small child, it will forget. So it has to revise. So you have to keep updating the software. So you have to make sure that you make the linguistic patterns again and again. You have to feed it in at correct intervals so that it does not drift. Now we come to the part which I think I got stuck with this presentation because I was overeager. And I had just used Heidi AI in Australia. And I came back and I was baffled. I was like, oh my God, I can do so much documentation and the time taken is very less. So I put it on the group. So everyone thought that, wow, this person must know a lot about AI, which I don't know. I profess that I'm not the person who knows much about AI, but I do use Heidi AI. So I can tell you about the transcription. So how does AI transcription and scribing work? So first of all, very, 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 very important is the consent. So one problem with consent from our patients is that do they have capacity? So especially with psychotic patients, there is a gray area. But if your institution has obtained consent, let's say your institution has said that we are going to use Heidi AI or any other transcription device, then you don't have to take separate consent from every patient. But if you are a private practitioner, this is a very tricky area. You need to take written consent, or at least you should record the consent somewhere so that it comes in a written documented format. So obtain consent. Second is, what does it do? It records the clinical conversation securely. Securely. We know that nothing is secure, right? We know that it can always be hacked. But they promise that in case it does get, they have several layers of security. They promise that in case it does get hacked, they will take the responsibility for it. So we have to trust someone. So here it says that what it does is records the conversation and then it starts transcribing it. It converts the speech to text with natural language processing. Why is it important for it to be AI and why can't it just be a general, like speech to text? Speech to text will not understand the context, whereas NLP will understand the context. So if you've had a patient who has come to you 10 times and you know exactly how they behave when they're depressed, manic, or they, when their psychotic symptoms are worse, it will actually know, the AI will actually know that this person is becoming psychotic. This person has said this in the reference of that. So it will not look extraordinary. Whereas it will look extraordinary if it comes as word to text. So in this, then it can export to EMR system. Right now in India, it has not been integrated with any EMR. Practo and some other health picks and all are trying to get it integrated, but there is a problem with that. Then, but in other countries, it is already integrated into EMR, so it can actually send letters to the GP. It can send letters to, that's the general practitioner. It can send letters to anyone who's involved, and only after you say yes to it, of course. And then you have to review and sign it, and you have to make edits to it. And then the last is that you can also use it to form other structures. So for example, you want to take out a medical certificate for your patient. Then you can have a set format. It can come out in that format. If you want to send a letter, let's say, to an orthopedician for a patient, then it can change it into that format. So it is a one-stop shop for any kind of dictations, any kind of formatting, any kind of structure. What are the benefits? It saves 8 to 5 minutes per patient encounter, 8 to 15 minutes per patient encounter. It reduces burnout and after-hours documentation. But what are the pitfalls to watch out for? Hallucinations. It can hallucinate, it can insert words. So it is very important that you don't become lazy and you don't check it. You have to check it, and then you have to always correct it before sending it off. And the other problem is accent recognition. It still has some trouble understanding different kinds of accent. Also, the interesting thing is that Heidi AI and other AIs which are transcribing have learned more than 180 languages now. So Tamil, Hindi, all these languages are recognized, but the problem is it is still not very clearly or seamlessly integrated. So it understands the context, but it is not able to understand the exact connotation. So for example, if somebody says that எனக்கு ரொம்ப சோகமா இருக்கு, வருத்தமா இருக்கு, செத்துறணும் போல இருக்கு, so it will just put it as such. It will say this person, it will say I am depressed, I feel like dying. So it will put it exactly like that, but it will not understand maybe the connotation of some kind of idioms. Mera dil toot raha hai. If you say, oh, my heart is breaking, so it will put it like that. It will say my heart is breaking. It will not be able to understand the context yet. So yeah, we have talked about all of this. So, but I'd like to tell you about the psychiatry format templates that it already has. So mental status examination, much better than what we write. We generally write MSc, all, at least I do it. I don't know if everyone does it. That will say, oh, general appearance and behavior, normal, everything normal, right? This one says, oh, general appearance and behavior. It has not even seen the patient, but it will describe based on what context you have given. So patient is well dressed, well kempt. Then after that, it will tell you eye-to-eye contact was maintained or not without seeing the patient, but you have to correct that. Then it will tell you the kind of delusions. It will give you examples. Oh, that person said somebody was following, என்ன வந்து யாரோ ஃபாலோ பண்ணுறாங்க, அவங்க வந்து இப்படி பேசுகிறாங்க, எனக்கு கேமராஸ் ஃபிட் பண்ணி வச்சுருக்காங்க. It will give everything, and then it will give delusions of persecution. So it will give you everything in a written format. So you don't have to worry about quoting the patient. It will quote it for you. And of course, we are trying to, people are not we, but people are trying to get it integrated into Indian EMR. And of course, it does time savings. I just wanted to show you how it looks on the phone. This is on the phone. So it's very easy to use. You just open the heidihealth.com or any other transcription. Then you go to new session. Then it starts transcribing. You press the transcribing button. So it starts transcribing. Then what do you do? After the session, you just choose one of the formats. There are lots of formats. These are the ones I could get on this picture. For example, this is just a fictional patient. So I spoke for like 25 minutes to get this fictional thing. So it then creates, after speaking, it creates this kind of format. So history of presenting illness, past history, so and so, follow up. It also tells you psychotherapy plans and strategies. Discuss past experiences with different labels and try to understand himself, noting that he is now more comfortable and normal. So follow-up appointments also. It also gives you a risk assessment. So all of this will be taken care of. Legally, you are covered because it goes for risk assessment. Everything will be covered. He said, she said, they said, everything will be covered. So allegedly will come up in the presentation. So it will not say his wife hit him. It will come as allegedly his wife hit him. So all of that is already fed in this. Now I won't go into this in detail, because these are all the AIs, transcription AIs, but none of them are available in India. Of course, you can use all of them, but then look at the amounts you have to pay. They're all a bomb. That's like $750, $830. Heidi AI is general, the basic AI is free, but of course, if you want proper templates, then you have to go for the paid version. Yeah, so we talked about this already. So 40 to 75%, reduction in documentation time. But yes, I have had many instances where patient will say, I have been having a lot of stress lately. Then it will write, I have been having a dress lately. And there are other, like major issues with it hallucinating, which I'll give an example. So Indian EMRs, this is just a hypothetical thing. We are not sure yet that it's going to happen. But if there is an ambient scribe, once there is a transcription device in India, then it will export it to the EMR system, and that will just get linked to the Ayushman Bharat digital mission or the unified health interface. That is the plan. I mean, I read somewhere that that's the plan. So some of the Indian EMRs which are trying to do this, which I know is Practor-A, HealthPix and DocPlus. And it also, they're trying to make it compliant with the Digital Personal Data Protection Act. This is something that we should all know about, 2023 Act, which requires appropriate consent, data localization and audit trials. Data localization means that the data has to be in India. It should not go out of India. So you should have a local server for the data. So if Heidi AI decides that, oh, I want to store all of your patient details in Australia, then you're in big trouble. Now, some of the bloopers, I thought it was funny. So I have frequent headaches came up as I have frequent bread aches. So then I said to the patient, have you had any thoughts of harming yourself? Then the AI transcribed, have you had any thoughts of harming yourself? The other one that was interesting was, I have been having trouble sleeping. The AI said, I have been having trouble sleeping. Sleep onset latency is 45 minutes with 3 awakenings per night. That was a completely imagined one. So if it is, if it is too clinical, sounding too clinical, then it is not true. So please make sure you correct your letters. Now, in terms of chatbots, sir also mentioned about chatbots. Some of the chatbots that we are using for patients are Wobot, Vaisa. These are all Indian. By the way, Vaisa is an Indian one. Wobot, Vaisa, Uper offer CBT, ACT and DBT informed mental health support, and they are really, really well, well taken by the youth, especially. They come to you and say, oh, I'm using this chatbot. So it is nothing new for them. It may be new for us. So then the good thing is that they have 24/7 access. A lot of patients want you to be around all the time for them. So this actually replaces that for some time, at least. So they can ask anytime, I've been feeling anxious, I feel panicky. It will give you, some immediate tips. And there is certainly higher engagement, especially among young people. But the limitation is that it has problems with crisis handling capabilities and scope boundaries. Sometimes it thinks that it knows everything. So one of the things with all AI is that they think they know everything. And secondly, they think that they have to please us. So they will tell you anything. So if you say that, I want something to prove that, my patients are improving better than others, then it will say, oh, this doctor's data shows that 80% of our patients are improving. So you ask it, how did you find out that it was 80? You can ask that question. You can ask, how did you find out? Then it will say, oh, I'm sorry, I did not have any basic, I didn't have any proof to it. It will apologize, at least it apologizes. But it is very dangerous because if you use that data, then you become, you're actually lying. Now, evidence for digital CBT shows that there is approximately 4.2 points down on PHQ questionnaires and 3.8 on GAD questionnaires. So it works better with neurotic illnesses. Of course, it does not work as well with psychotic illnesses. And the engagement rate is 83%, whereas it's only 28%. We know this with self-help materials. And we just have to note that this is amongst a trial population. It's not among real-world surveys. This is a sample conversation, but I just want to ask you one more question. How many of you have used ChatGPT for emotional reasons? Wow, I can't believe it. There are only very few of you who are, that's very nice because I use it almost every day to deal with my adolescent son. So parenting, you know that there is ChatGPT and other AIs are mostly being used for emotional reasons. Almost 90% of the questions that are asked to ChatGPT are, what should I do today to, overcome some problem with my husband or with my boyfriend or whatever. That's being asked in ChatGPT. So now monitoring. This is also something that we talked about, right? Sir talked about. So when you need to monitor someone who has some issues, is at risk, what can you do in that case? Again, you can do it in between sessions, check-ins, adherence nudges and journaling prompts, mood tracking. This can be done by voice assistants. And it also catches, again, it catches the prosody, tempo, sentiment analysis, acoustic patterns. What we talked about with others, it can catch that. And it also does what, if it is connected with your EMR, it can actually directly give a prompt on the EMR, and the psychiatrist or whoever is involved, the team, can be notified. And they will be told whether this person is deteriorating. You can see the example there, that let's say day 14, I've been feeling a bit better this week, managed to go outside twice, still having trouble sleeping. So positive sentiment up, speech rate better, vocal energy down. But this patient is not doing so well. Positive sentiment down, speech rate down, vocal energy down. So the risk alert is triggered. Now, who is seeing a problem in this? There is, as senior clinicians, as senior doctors, we know that this can be, something that happens to people. Ups and downs happen all the time, right? If a person is depressed, they're doing really well, but suddenly they have a down, that doesn't mean that they're going to have a relapse. And it doesn't mean that they're not doing well or suicidal. But this alert will trigger. So you have to act on it. If you don't act on it, there can be legal consequences. So there is, of course, there is a threshold that, if you are going to act on it, you need to know that this person is at risk. You don't need to act if they're just saying that they're, feeling sad. But still, it is a risk for the clinicians because it can cause legal issues. There are wearables now which can be used for heart rate monitoring. We all are wearing those wearables, but now they are also, calibrated for behavioral patterns. So what does it do? It can get location data, communication patterns, screen usage and typing dynamics, and it can use those algorithms for anomaly detections. So there are some cases where it has predicted that this person is going to a place where they shouldn't be. So this person was suicidal, they went to the cliff, and this AI detected that he's going to the cliff and it alerted the ambulances. But those things are very rare. So those are, things that are really exceptional cases. On a day-to-day basis, they are not as useful because of the fact that they require regular recalibration. So, because it's physiology and it's wearable on the body, it has wear and tear, and it needs to be recalibrated almost every month. Now, I'm sure that we are not actually using that many wearables on a day-to-day basis, I guess, right? So I'm skipping this poll. Now, AI-powered EMRs in India, this is a very basic, I'm not very sure of this data. This is the data that I collected through, my search, Google search and AI searches. So it says that HealthPlix, Practore, DocPlus and Care Expert are trying to integrate. So for example, they do have specialty templates and they have automatic coding and all that, smart prescription suggestions, all that is there. They also have, Practore is now coming up with an interaction checker. So if you write something and then the patient on Practo has another prescription, then it will alert you. It will tell you that, oh, this prescription doesn't match. So this drug should not be given. But these are all basic AI. They are not very, forward AI methods. They are just basic AI methods. I will skip this again because I'm not too sure of how much this is actually happening. I just know that these platforms are trying to integrate AI. There was this one example given, and this I have to quote another presentation that I attended. They gave me this data that one of the persons on HealthPlix EMR, there was a suicidal risk and it was flagged, and it was caught through NLP note analysis. So natural language processing note analysis. So this was helpful because it reduces, it says that this kind of catching can reduce missed safety signals. Now, in terms of our clinic management, what is the benefit of these kind of AIs? One is that it will reduce no-show. How does it reduce no-show? It can predict. It can predict whether a person will show up or not. So if you are giving appointments and you have given appointments to this person regularly and this person has not turned up, so it will allow you for a double booking in that slot because it knows that this person may or may not turn up. So you are actually losing less time. Second thing is, of course, administrative time is improved, and also there is the output that there is more efficient scheduling time. So the patient is sent reminders, they're asked to come, and they're also asked for feedback. So it also keeps the patient engaged. Now let's look at the systematic evidence. So diagnostic accuracy, we said 80 to 90% improvement. 80 to 90% diagnostic accuracy of the tools. Therapy effectiveness, small to moderate, only in not severe cases and neurotic individuals. Operations efficiency, 40 to 75%, which is really good for a person who's running a clinic. So these are all things that can improve with the AI. Now, in terms of meta-analysis, 85% diagnostic accuracy, 78% user satisfaction, 50% time reduction. These are all from the studies that I've quoted. Now, let's look at this case and just tell me what you would do in this case. So, a 32-year-old person with MDD, they've had 3 or more major depressive episodes. So, this patient enrolled, this is a real-world case, but it's not a real-world case, it's a clinical trial case. So, the patient enrolled in weekly voice monitoring program after successful treatment with SSRI and CBT. So baseline was established during the stable period. Then the Kintsugi voice trials were done. So 60-second weekly check-in calls were done. So voice signal detection, week 20, AI detected increased pauses between words. 35% increase from baseline. Week 21, reduced pitch variability, monotony. Okay, and alert was, a system-generated alert was sent based on this. So, okay, so I will need 5 to 6 minutes more. So, this patient was caught around 3 to 4 weeks before he actually had a full-blown episode. But because it was part of a trial, I think they didn't start a medication. But they did have regular checkups after that. And this was another mind-blowing thing that, they were rural telepsychiatry, bridging the rural gap. How can we do that? If a person, let's say from Maharashtra wants to talk to you, what do? You don't understand Marathi. But the mind-blowing thing is that you can actually convert it real time into Tamil or English. And you can respond in English or Tamil and it will convert it into Marathi or whatever language the other person is speaking. And there is a 92% translation accuracy. So I will skip this because it talks about the same thing. Now, the problem with AI detection, that is diagnosis, is that one is that there is poor data quality as of now. Secondly, we have bias and cross-cultural validity. We know that most of the studies are always done in the Western context. There is safety concerns because crisis handling situations and AI hallucinations can cause dangerous advice. There have been few cases where people have committed suicide based on AI advice. And of course, there is external validity limitations. Now, in terms of the legal issues, I've slightly touched upon this. Privacy is under India DPDP Act. Medical data is as sensitive as your personal data. So you have to treat it like your personal data. And cross-border data comes under HIPAA and GDPR. So consent has to explain all of this. It has to explain that you will be storing it in a local server. Now, if something does happen, like for example, this person, they're talking about this case where a 24-year-old got unwell, and they talked to the AI, but the AI said, oh, everything is all right, you're fine, wait for some time. Then what will you do? The patient's condition deteriorated, and they required hospitalization. So, and this young person said that, the AI's responses were making him feel hopeless. So, in this case, who bears primary liability? Is it the AI vendor? Is it the clinician? Is it the healthcare institution? Or is it a shared liability? As of now, the cases that have come up in other countries, the liability is of the AI vendor, but it can change anytime. Of course, we know what are the AI limitations. AI limitations are automation bias, skill atrophy, and data drift. So data drift we talked about. Skill atrophy is when we stop using our brains. We start saying that AI is doing everything, so why should I do anything? So then in that case, we won't be learning anything. And automation bias is that we have a tendency to accept AI recommendations without scrutiny, be it for us or for the patient. Human strengths are empathic connection, clinical intuition, ethical management, and cultural sensitivity. But AI has a huge capability of data processing and pattern recognition. So, and it is also consistently available. I'm going to skip this. Now, AI was able to design multiple antibiotics for gonorrhea and MRSA superbugs. Till now, AI has made more than 100 antibiotics, new antibiotics. So this is really good news that AI can be used in this manner. Now, I know that this was probably the most important thing for all of us. When we write, we are very, very busy. Otherwise, in clinics, we don't want to use time to write. So I'll just go through this. I'll just give you the names. I won't take too much time. So we have ChatGPT, which is OpenAI, Claude, Anthropic, Perplexity AI, and GenSpark AI. I'll just tell you where to use what. ChatGPT can give you a good general outline of anything that you want to do. Claude will give you all the bar graphs and all the graphs that you want to put into your presentation. Perplexity will give you the correct literature review. ChatGPT will lie to you. Perplexity will not lie. So ChatGPT makes up references. If you want to, that's a very funny thing. It does do that. Whereas Perplexity AI will give you the correct references. Then GenSpark AI can put all of this together. It has a very good ability to combine everything and give you a very comprehensive presentation. So, in terms of creating an academic presentation, Gamma AI can be used for beautiful slides, and GenSpark slides can also be used, and ChatGPT and Claude can be used. So, yeah, I'll stop now. If anyone wants this presentation, they can take it from me. Just to let you know that this presentation was created with AI. So,
thank you, Dr. Janaki. An excellent and very good presentation. Actually, the recent study says that doctors who is using AI has less burnout than who was not using AI. So AI has decreased the burnout for the doctors. I think AI is very, very important in current scenario. Because of the time constraint, we can take 2 questions from the floor. Only 2 questions. Anybody?
Not about question. My personal experience or my personal observation is regarding AI and its uses. They are not abstract. We can say they are concretely abstract. We need an abstractly abstract instrument that can almost simulate a human being with empathy. So currently, I will say it is concretely abstract. Whatever you give, it can direct, it can design, it can synthesize, but it is not abstract. It is concrete one. All the process is concrete.
This is Dr. Preeti.
Thank you for your wonderful presentation. As you said, I use ChatGPT a lot, mainly for emotional reasons. Why my daughter does this, why my son, to understand the Gen Z population. What was the thing was, I was searching for Achamum Nanamum Naigatku Vendumam. Give me a katurai. And it totally missed what Bhardiar said. It said that if even dogs should have this, people should always have. Bhardiar had told that for women empowerment. So it totally missed the context. Right. So as Dr. Kumanan was saying, we have to be a bit careful because I'm using a lot, no doubt in that. Your take on that.
Thanks. Yeah. So that's very true, ma'am. So ChatGPT, you have to give it a, when you make a question for ChatGPT, you have to be very careful about the input. So for example, if I want to make this presentation, if I say I want to make a presentation on AI in psychiatry, it will make a very generalized presentation. But if I say I'm a psychiatrist, I want to make a 1 hour CME presentation for a group of psychiatrists in Tamil Nadu, in India, then it will make a better presentation. So you have to tell it the context. So if you're, for example, this, it will not understand the cultural context at all. You will have to give the context and then say that this is what I want. Then it will generate something. Yeah, thanks.
Thank you. I think I want to share two of the very good examples regarding AI which helped me. When I became the president of, before taking the charge as the president of Tamil Nadu IPS, I want to give a presidential message. And I informed my colleague doctor, இந்த மாதிரி பெர்சன்டேஜ் பண்ணுறதுக்கு என்ன சார் என்ன பண்ணலான்னு அவர் ஒன்றும் இல்லை சார் நீங்கள் ரஃபாக எழுதி ஏஐயில் போடுங்க சார் எவ்வளோ நேரம் பேசணுமோ அவ்வளோ நேரம் போட்டு விடுங்கன்னாங்க தென் ஐ ரஃப்லி ரிட்டன் அண்ட் ஐ ஃபிட் இட் இன் த ஏஐ அண்ட் ஐ செட் ஐ வாண்ட் த ப்ரெசன்டேஷன் ஃபார் 40 minutes. It gave a beautiful presentation. அதான் ப்ரெசென்ட் பண்ணேன் ப்ரெசன்டேஷனில் such an excellent things. It's very less provoking for the doctors. And then it's a very deep learning is very, very high with AI. ரீசெண்டாக இப்போ ஒரு 2-3 days முன்னாடி சடனாக என் பொண்ணு பார்த்தப்பா நீங்கள் விஜய் ஃபேனான்னு கேட்டான். ஏம்மா அப்படின்னு கேட்டேன். இல்லை அவங்க இன்ஸ்டாகிராமில் பார்த்தா எல்லாம் விஜயா வருதே அப்படின்னாங்க. Because I was searching for the Karur incidents and Janaki movies I have been seeing for the past couple of days. Automatically when I open my Instagrams, everything is related comes to that. ஒன்று I feel happy. And I think I'm getting addicted also. ஏன்னா அதை பார்க்கணும், it motivates me. It gives என்ன எனக்கு லைக் என்ன இருக்கோ அதை கொடுக்கறதுனால actually it forcing me to go through this thing more and again. So அந்த மாதிரி some advantage as well as some disadvantage also. So as the Indian Psychiatric Society are recognizing the importance of AI, they have formed the Artificial Intelligence Machine Learning Subcommittee, IPS subcommittee. I was the president of that IPS subcommittee in that All India IPS. நான் தான் பிரசிடென்ட்டாக இருந்தேன். Then we recommended to do something because lot of AI related apps and nothing is coming in our recent days. So we recommended to our incoming president Dr. Saudha Mulgatra madam, and Saudha Mulgatra madam formed a accreditation subcommittee IPS accreditation for the accreditation subcommittee. So if anybody comes with an AI app or something, you will integrate lot of apps, especially for நிறைய இந்த மாதிரி ஈவன் நம்ம கன்சல்டேஷனுக்கு இந்த மீட் டைம் இந்த சிபிடி மாதிரி lots of coming up. We want an IPS who want to streamline that. We want to standardize that. So IPS we started a mechanism. So Dr. Chaturvedi was the chairperson. I am the co-chair of the accreditation committee. We got 3-4 app, especially on AI app. One is on counseling. So we rigorously we selected, we sent it to the specialists, and it's on under the process. Probably during the IPS Delhi, we will give the report and we'll suggest some of the thing we are not very comfortable one of the app. So we are in the discussion on America. So there are some time is there for the chief guest to come. Any other questions? You can ask 2 more questions.
Good morning. That was an excellent presentation. Mine is not a question, sir. It's just
you can share
share my experience.
Yes.
When it comes to presentations preparation, I personally felt compared to ChatGPT, Perplexity works wonders because it's too good that now it's paid. And in Perplexity is suppose we're going to put a prompt like give me a presentation for a workshop with 10 standard students on life skills. So that's going to give it with all headings. It's going to give a wonderful tabular column summarizing, and it also suggests certain associated thought-provoking questions related to the topic. So from there we go very relevantly next to the topics, and it's too good. And I think there's another AI where we can create videos with prompts describing, say for example, get me a video on a student getting bullied in the corridors of the school by the peer group, and we have to give the clear prompts, and it gives a very beautiful video, both animated and real life this thing. So those are things which have really helped me in my workshops with the school children and all that, and it's good. That's my feeling.
Very good, madam.
Thank you.
What are the any disadvantage, major disadvantage, especially psychiatry is concerned regarding AI? You said that in in documentation, other thing. They says that it's help a lot in documentations. And also give the diagnosis also. If you talking to the patients and you talk, it will record also. Record the conversation of the both the psychiatrist as well as the patient. In the meantime, it gives impression also. And also it gives suggestions. Probable diagnosis, probable treatment option, what you would give. If there is anything you want to comment about that?
It does tend to bias, sir. It tends to bias the clinician. Sometimes it has a completely different diagnosis. As a senior clinician, people understand something, nuances that the AI will not understand, especially it's not seeing body language. So it will give some kind of suggestion and it will bias the clinician. And sometimes we second guess ourselves. That is one thing. Second thing is, of course, the privacy. Privacy and security is a major issue. That we have to be very careful because it can always leak the data. And, hackers can use it.
Lot of other things also, like example for prescription. Any app the game for the prescription also. Whenever you enter a drug, for example, if you are typing clozapine as well as carbamazepine, then you need to interact in the bottom. It comes that be careful. The drug allergy is more. So a lot of things also comes in this. You think some health picks some app.
Yes. Yeah.
That's a lot of advantage. In the meantime, disadvantage is that the human cannot recognize the human face, a conversation. That's the only thing. Otherwise, do you feel it's the more advantage and disadvantage? What do you, from your literature review, your personal judgment, whether it's advantage is more or disadvantage? What do you feel that?
As of now, I feel it's more advantages. But we don't know in the future.
Radiology, they have a great role in radiology, radio diagnosis. Radiology எல்லாமே ஏ தான். இப்போ எம்ஆர்எஸ், எம்ஆர்ஐ, whatever maybe, எல்லாமே ரொம்ப ப்ரிசைஸாக it gives. ரொம்ப டயக்னோசிஸ் எல்லாமே வந்து doing a lot. எல்லாம் அல்ட்ரா லேட்டஸ்ட் ஸ்கேனு எல்லாமே வந்து does wonder in radiology department and many other specialty, especially radiology. AI is fully 90% of radiology based on AI only. நிறைய டாக்டர்ஸுக்கு வேணும், பட் இருந்தாலும் அந்த ரேடியாலஜிஸ்டோட விட நிறைய அவங்களுடைய ஒர்க் மென்டல் ஒர்க்கு எல்லாம் அவங்களுடைய கிளினிக்கல் ஜட்ஜ்மெண்ட்டோட பண்ணுறதுக்கு ரொம்ப ஈஸியாக கிளினிக்கல் ஜட்ஜ்மெண்ட் கொடுக்குறது ஏஐ இருக்கிறதுனால. சார், யூ கேன் கமெண்ட் எனிதிங், சார்.
Thank you, ma'am, for your futuristic presentation. Now we request the chairpersons for honoring the speaker.
Thank you. Thank you.
Now we request Dr. Arul Prakash sir, the President of Indian Psychiatric Society South Zone, to honor Dr. Pannirselvam sir.
Now we request Dr. Sadanand sir, the President of the Indian Psychiatric Society TN Chapter, to honor Dr. Vishwanathan sir. Thank you, sir and ma'am. It's an immense pleasure to welcome our esteemed chief guest, Professor Dr. Shanmuga Sundaram sir, Medical Superintendent, Government Erode Medical College and Hospital, and guest of honor Dr. Venkatesh sir, Pediatrician and Hospital Superintendent, Erode Headquarters Hospital. Now we now we will be moving to the inauguration session, and I kindly request all to be seated. This moment marks not just the beginning of a new chapter, but a celebration of vision, dedication, and collective effort. We are honored to welcome our esteemed chief guest, Professor Dr. Shanmuga Sundaram Sir, Medical Superintendent, Government Erode Medical College and Hospital, and guest of honor, Dr. Venkatesh Sir, Pediatrician and Hospital Superintendent, Government Erode Headquarters Hospital.
Also, we welcome the following dignitaries: Dr. Saravanan Sir, the Organizing Chairman; Dr. Sanandan Sir, President, Indian Psychiatric Society, Tamil Nadu Chapter; Dr. Arul Prakash Sir, President, Indian Psychiatric Society, South Zone; Dr. Arun Kumar Sir, Honorary Secretary, IPS, Tamil Nadu Chapter; and Dr. Jayaprakash Sir, Organizing Secretary; and Dr. Anandakumar Sir, and Dr. Navanithan Sir, and Dr. Nagarajan Sir.
We also welcome Dr. Babu Balasingh, Vice President, IPS, Tamil Nadu Chapter.
மதிப்பிற்குரிய திரு பி கண்ணன் ஐயா அவர்களையும் மேடைக்கு அழைக்கிறோம். இவ்விழாவின் முதல் நிகழ்வாக தமிழ்த்தாய் வாழ்த்து.
நீராறும் கடலுடுத்த இளமடந்தை கெழிலொழுகும் சீராரும் மரணமே திகழ்வரத எக்கணமும் அதிசிறந்த திராவிடன திருநாடும் சிறு திருநுகள் தரித்தலரும் திலகமுமே திலக வாசனைக்கும் அனைத்துலகும் கித்திசையும் புகழ் வளர்த்த இருந்த பெரும் தமிழனுக்கு சீவிழமை திறப்பியல் செய்வதற்கு பார்த்ததுமே
Now we invite Dr. Saravanan sir, organizing chairman, for the welcome address.
Good afternoon, everyone. On behalf of organizing committee, I have immense pleasure in welcoming you all to this annual midterm CME of Indian Psychiatry Society Tamil Nadu chapter being held in Erode for the very first time. I have special privilege to welcome our dynamic medical superintendent of Government Erode Medical College and Hospital, Professor Dr. Shanmuga Sundaram sir, who is here our chief guest to inaugurate this CME. I welcome our efficient hospital superintendent, Erode District Headquarters Hospital, Dr. Venkatesh sir, who is our guest of honor to inaugurate this CME. I welcome our senior psychiatrist, respected Dr. Arul Prakash sir, our Indian Psychiatry Society South Zone Branch President. I welcome our close friend Dr. Sadanand, Indian Psychiatry Society Tamil Nadu Chapter President, Dr. Babu Balasingh sir, TNIPS Tamil Nadu Vice President, and Dr. P.P. Kannan sir, IPS Tamil Nadu Branch South Zone, representative to South Zone, and Dr. Arun Kumar, our active secretary of Indian Psychiatry Society Tamil Nadu Branch. And I also welcome all our other office bearers of Indian Psychiatry Society Tamil Nadu Chapter. I gratefully welcome all our eminent speakers who have gathered here, having gracefully accepted our invitation to enlighten us on various topics. I welcome all senior psychiatrists, all our colleagues and friends from various parts of Tamil Nadu who have joined us for this CME. It also gives me a lot of happiness to welcome the minds of future who are budding psychiatrists pursuing post-graduation in various institutions of our state. I'll be happy to welcome Senior Ogician Dr. Rajalakshmi, mother of our Dr. Sadanand sir. Amma is here with all her prayers and blessings. We are successful in all our endeavors. And a warm welcome to the spouse, family members and other accompanying persons of our delegates. I thankfully welcome persons representing various companies of pharmaceutical industries who are helping us in organizing this event. We welcome young undergraduates of Government Erode Medical College and Hospital who are here to assist us in conducting this event in a grand manner. And I once again welcome one and all for this event. Thank you.
தேங்க்யூ சார். அறியாமை நீக்க ஆசான் ஏற்றுவது அறிவிளக்கு, சான்றோர்க்கு பொய்யா விளக்கே விளக்கு. இவ்விழாவை சிறப்பிக்க நாம் ஏற்ற இருப்பது குத்துவிளக்கு. விளக்கின் 5 தீபங்களையும் ஒரு சேர ஒளியேற்றி இவ்விழாவை சிறப்பிக்க நம் பகுத்தறிவு பகலவன்களை அன்புடன் அழைக்கின்றோம்.
பண்ணுங்க சார்.
சிற்றொலிகள் தான் பேரொலிகளை உருவாக்கும் என அகல் ஜோதிகளை ஏற்றிய அறிவர்க்கு நன்றிகள். We also welcome Dr. Ramesh Babu sir, Observer, Tamil Nadu Medical Council. Now I request Dr. Sadanand sir to honor our chief guest, Dr. Shanmuga Sundaram sir.
Now we request Dr. Saravanan sir to honor our guest of honor, Dr. Venkatesh sir.
Now I request Dr. Jayaprakash sir to honor Dr. Arul Prakash sir.
Now we request Dr. P.P. Kannan sir to honor Dr. Arun Kumar sir.
Now we request Dr. Arun Kumar sir to honor Dr. Babu Bala Singh sir.
Now we request Dr. Babu Balasingh sir to honor P.P. Kannan sir.
Now we request Dr. Anand Kumar sir to honor Dr. Saravanan sir.
Now we request Dr. Navanithan sir to honor Dr. Sadanand sir.
Now we request Dr. Kavita ma'am to honor Dr. Jayaprakash sir.
Thank you sir, ma'am.
Now we request Dr. Sadanand sir, President, Indian Psychiatry Society, Tamil Nadu Chapter, for the presidential opening remarks.
Good afternoon, everybody. I'm welcome our chief guest, Professor Dr. Shanmuga Sundaram, who's a medical superintendent of Government Erode Medical College, and our guest of honor, Dr. Venkatesh, superintendent of District Headquarters Hospital, and our South Zone President, IPS South Zone President, Dr. Arul Prakash, and other office bearers and the organizing team on the dais and off the dais, and other seniors, friends, and colleagues. I'm happy to welcome you all to this gathering. And this year, this is the first official event which is offline. And though we have had many online programs, webinars, in the last few months, and by the various after I taking over in July, so by the various committees, and some of the committees is the RCBC, the Research Capacity Building webinars. They have conducted for the postgraduates around 3 webinars, and another one is upcoming soon. And that is headed by again Dr. Shivanand Katimani, who's also here today. And other than that, the scientific committee, subcommittee, which is again, which is under the chairmanship of Dr. Raman, they have also conducted child psychiatry webinar series, and they had one of the seminars where it was highly appreciated by many on the Zoom platform. And similarly, the Women Empowerment Committee, also led by Hema Tharoor, they had conducted a webinar on trans-binary narrative of a doctor. That again had a very good, was appreciated by many. Because generally you don't get in-person's experience, personal experience, and how things can be corrected. So a lot of learning happened in that. And similarly, the Mental Health Establishment Committee, again headed by Dr. Venkatesh Kumar, we had many discussions on minimum standards by the mental health in coordination with the programs organized by the State Mental Authority, and also there's discussion going on and also we have a representation in that group by our Dr. Arun Kumar, our secretary, and a lot of discussion has been going on, and probably soon we'll have a regulation, state mental health regulation for our state specific. So probably if we have come out soon, probably we might be in the southern states, we might be first. I think so. And other than that, there's newsletter committee, which is again headed by Dr. Gopinath, and we'll be releasing the newsletter shortly after in this event, subsequently, and also this midterm CME. This is unique, I thought, because it is last few years only specifically for practitioners. There was a need felt, and specifically for practitioners, the idea was born. And we decided this time to have topics, not the usual topics, something beyond practice for practitioners specifically, and so many other views in mind, discussed with the organizing team, and we are able to, since I am also part of the organizing team, we were able to get to come a conclusion from finance, technology, as well as adolescent problems. These are some major issues which we need updating in many of these. It should not be the regular academic we have in the conferences. So I thought since it is for practitioners, we should be learning much more beyond that. So that was the idea. So I think so far people would have appreciated that, and probably would be enjoying, and hopefully each one of you would be enjoying this academic feast, unless the go back with fulfilled, that you have learned a lot of things which will help you in your practice in facing the challenges. And hopefully the future CMEs probably will improve the standard much better. So better than this CMEs. So it will be nice, so we can improve our standards of our psychiatry fraternity. Thank you.
Thank you, sir. Now we welcome Professor Dr. Shanmuga Sundaram, sir, Medical Superintendent, Government Erode Medical College and Hospital, for the Chief Guest Address.
Respected President of Indian Psychiatric Society, the other Secretary and other office bearers of the Psychiatric Society of Erode Chapter, other professors and dear colleagues and students also there. Good afternoon for all. I am very glad to see that our Department of Psychiatry in our college is participating in this conference in the district level. And I feel happy that I was invited here as a guest. Actually, our Dean sir was invited, and suddenly he has to go to the camp in Talavadi. So he went there, and instead of him, I came here as a chief guest. I thank for that honor given to me as chief guest for the society. Thank you. And I came half an hour back, and I was able to get the topic. Madam was speaking about artificial intelligence. So recently, I was also having that thought of artificial intelligence. How about learning artificial intelligence and all? I am now 56 years old. So still I am having interest. I think it is a காலத்தின் கட்டாயம்னு சொல்லுவாங்களா அந்த மாதிரி. It is a time you have to learn like this. But only thing is, what I have, a lot of doubts are there in that. One doubt I will tell you. About 20 years back, if you go to the normal bank and all, you can able to see old age people also there, and then young people also may be there, but most of them are old people. But now, if you go to any bank, very hardly you can see the old people there. Do you know the reason why? I think everything is computerized nowadays. There is one app called Finacle, I think. Finacle. So every bank, if you open the computer, you'll get that Finacle. that app is there, but it is digitalized and computerized, whatever you call it as, and every bank is connected, and very hard to work for old people. So many people, even my father-in-law got VRS. He is a bank manager and he got VRS. 3 years before retirement, he got VRS. I asked him why. He told the reason. We could not manage the computer and all. This one scenario I am telling in banking industry around 20 years back. Now, I think the same problem will happen in our industry, not industry, in our field also, I think. If you give more and more importance to this AI, it is beneficial or it is not beneficial and all, it is different. But I'm having doubt whether this AI will replace only the young generation in all the fields. This is one doubt I'm having, and I think unlike other departments or industry or the field, our field is not having more importance to what is called human touch. That is the only thing I think that will save us from this AI that is penetrating or infiltrating our field, I think. So we are having more of human touch in our practice, and that is what expected from the patients. So I think that if you have that component more and more, I think we will survive and we can, what do you call it as, we can avoid these things like problems coming because of this AI or some other digitalization or computerization, all these things. So whether it is good or not, I am not discussing about whether it is good or it is not good like that. But I am telling, if we get more and more this computerization and AI, so many things and all, then the importance of old people, I think, will come down. I think this is my doubt I am expressing here. And I think, again, I wish this conference get a good success. And once again, I thank for this opportunity. Thank you.
Now we welcome Dr. Venkatesh Sir, Pediatrician and Hospital Superintendent, E-Road Headquarters Hospital, for Guest of Honor address.
அனைவருக்கும் இனிய மதிய வணக்கம். The organizing dignitaries of this conference and respected chief guest and my respected senior Dr. Pannisalvan sir from my hometown, he is my senior college schoolmate, my senior physician Dr. Adilakshmi madam, so and all the delegates. So once again I thank. ஸோ இது வந்து என்னென்னா, நம்ம டிஸ்ட்ரிக்ட் மென்டல் ஹெல்த் ப்ரோக்ராம் வந்து இட்ஸ் வெரி கீன் இன்ட்ரெஸ்ட் ஆஃப் திஸ் ஆல் கவர்மெண்ட். நம்ம அமைச்சர் பார்த்திங்கன்னா மனம் காக்கும் திட்டம்னு ஒன்று ஓடிட்டு இருக்குது. ஸோ வி ஹாவ் டிஸ்ட்ரிக்ட் மென்டல் ஹெல்த் டிஸ்ட்ரிக்ட் சைக்காட்ரிஸ்ட் அண்ட் டிஸ்ட்ரிக்ட் மென்டல் ஹெல்த் ப்ரோக்ராம்ஸ் ஆர் தேர், அண்ட் ஆல்சோ satellite psychiatrist is there, and it's run efficiently by Dr. Anandakumar, and district mental health program is run by Dr. Jayasundar and his team. One more psychiatrist I would mention in Andiur, Dr. Kavita is இங்கே மென்டல் ஹெல்த்னாலே அங்கே ஒரு பக்கம் கவிதான்னு சொல்லுவோம். சூசைட் ப்ரிவென்ஷனாக இருக்கட்டும், சரி எல்லா இது ப்ரோக்ராம், டார்கெட் இன்டர்வென்ஷன் குரூப், ஸ்கூல் ஹெல்த், மென்டல் ஹெல்த், ஸோ வெரி குட், எல்லாமே வெரி குட் அச்சீவ்மெண்ட் நம்ம எடுத்துகிட்டு இருக்கிறோம். எங்களுடைய டிஸ்ட்ரிக்ட் ஹெல்த் ஐ மீன் எவ்ரி மந்த் நம்ம ஒரு ஹாஸ்பிட்டலுடைய ரேங்கிங்கில் வந்து மென்டல் ஹெல்த் வந்து ஃபுல் மார்க் எப்போவுமே எடுத்துகிட்டு இருக்கோம். ஸோ சச் தட் நம்மளுடைய எங்களுடைய ப்ரோக்ராமை வந்து அந்த 5 பீப்புள்ஸ் இருக்கிறாங்க, ரியலி வெரி குட். ஸோ கன்யூ த அப்ரிசியேஷன். ஸோ இந்த சிஎம்இங்கிறது நம்ம ஒரு நாலேஜ் அப்டேட் பண்ணுறது. ஸோ தேங்க்ஸ் ஃபார் த ஆர்கனைசர் இன்வைட்டிங் அஸ், அண்ட் தேங்க்யூ ஃபார் த சக்ஸஸ் ஆஃப் தி சிஎம்இ. தேங்க்யூ ஒன் அண்ட் ஆல்.
Thank you, sir. Now we welcome Dr. Arul Prakash sir, the President of the Indian Psychiatry Society South Zone, for the presidential address.
Respected President of Indian Psychiatric Society Tamil Nadu Chapter, Dr. Sadanand, Chief Guest of the Day, Professor Dr. Shanmugha Sundaram, Guest of Honor Dr. Venkatesh, Organizing Chairman Dr. Saravanan, Secretary Dr. JP, Office Bearers of Tamil Nadu Chapter, Senior Professors and dear friends. A very good afternoon to one and all. First of all, greetings from Indian Psychiatric Society, South Zone. And this Tamil Nadu Chapter Practitioner CME is being held in a very nice manner. Thanks for inviting me and the hospitality provided to here. And as Dr. Sadanand told, actually this is the need of our topics. Morning also discussed about Prodrome and AI, and so many other good topics are about to come. So really a well thought and well organized CME will be a sumptuous academic feast for everyone, I hope. So my best wishes to the organizing team for having taken so much pains to organize the CME. And regarding South Zone, actually we have 5 member states, and in membership, Tamil Nadu is lagging behind Karnataka by some 10-20 numbers this time. So this is because the youngsters are not showing much interest in becoming a life fellow and joining IPS South Zone and national body. So I request all senior faculty members here, senior psychiatrists here, to gear up our juniors to join IPS in large numbers, so that Tamil Nadu should always have a better hand in deciding matters. And from IPS South Zone, we have planned to start so many programs, and importantly, a suicide prevention cell under the leadership of Dr. Pannisalvam. We are planning to start this year in a big manner and will be spread across all our 5 states, Tamil Nadu, Andhra, Telangana, Karnataka and Kerala. Especially among younger folk and student community, we are will be coming up with some novel scheme to prevent suicide among our people. Also, another one issue which is cropping up is this Mental Health Care Act, and so much of hardship given to our members. So that also we have discussed in South Zone, and hope we'll discuss in our EC and GB in Tamil Nadu also. It has been taken up by all other member states also. In South Zone, we have come up with a resolution regarding one event in Tamil Nadu itself. So this I just want to share the information with you. And about the South Zone activities, if any one of you have any novel scheme or any idea so that it can be spread across other states, please feel free to talk to me or Dr. Arun or any South Zone representative. Dr. P.P. Kannan is here. So feel free to talk to them so that we can implement in our member states. So thank you for the opportunity. My best wishes for the grand success of the CME. Thank you.
Thank you, sir. Now we welcome Dr. Arun Kumar, sir, Honorary Secretary of Indian Psychiatric Society, Tamil Nadu Chapter, for the Secretary report.
Respected dignitaries of the dais, on the dais, and my dear friends, very good afternoon to you all. 3 important things, highlights I have to mention. That IPSTN chapter, we have renewed in the Society Registration Act. So we are updated. Second, we have 528 members as on today, with 300 life members, and remaining are LOM. And we have 17 postgraduates who also joined our IPSTN chapter. And we urge more postgraduates to join our center so that it will be useful for their academic purpose. Second important highlight, we recently purchased a Zoom link. Earlier you used to collaborate with pharma companies. Now we have our own Zoom link with the help of our president, so that we can have n number of programs in the next coming year. We already started the program. 2 or 3 programs is running. So every week or every day also we can have a online platform so that whoever interested can attend that. And then third important is that the
community awareness program. So recently, we would have been seen that World Mental Health Day, Suicide Prevention Day, Alzheimer's Dementia Prevention Day, and all apart from these days also, promotion of mental health. So we had more than 100 programs that has happened on World Mental Health Day alone, by across Tamil Nadu, by all of members, and the evidence is there in our newsletter. So every person has participated, okay, that some program in the school or college level or public level camps. So we have a collection of data with their photographs and the event and the date and all. So it is overwhelming that we have done things. Then the third most important thing is a CSR project, which brainchild is our P.P. Kannan sir. Thanks to him. So this project is for the treatment-resistant schizophrenia patients. We have to enroll them, and we provide online counseling. We provide them guidance to how to get a disability certificate, how to get that unique Pradhan Mantri, that ID card, and many other things. We also have planned to get their blood test done on a periodic level. So this is only for the treatment-resistant schizophrenia patients on clozapine, because most of these guys won't be working and they have trouble with the medications itself. So this project we have initiated, and it has already started. We have enrolled 30 people in that, and we will be providing service for the next coming years also. We have even obtained funds also. And well, many such programs will be coming on, and we have compiled things. And regarding the mental health, that is minimum standard for mental health, this one, we have been discussing with the government, and our inputs have been submitted. They have also drafted, and in that they have divided 5 categories. I have shared that data into our groups, wherein we can see that how minimum things is required for a mental health establishment, either de-addiction center or a general psychiatric hospital, and how we have to manage acute cases, and then de-addiction, where to put, and what is the responsibility of a psychiatrist. So here the importance of psychiatrists is mentioned everywhere, and with that I think we will be safe, we can practice effectively. And thank you. Long live IPS.
Thank you, sir. Now it's time for listening TNIPS newsletter. Now, Professor Dr. Shanmuga Sundaram sir will release the TNIPS newsletter, and it will be received by Dr. Arul Prakash sir.
Thank you, sirs. Now we welcome Dr. Jayaprakash sir, Organizing Secretary, for the vote of thanks.
Good afternoon, everyone.
There is an old song in Tamil which says, Innarku innar endru eludi vaithane devan endru. I'm reminded of that song because we planned to invite the collector of the Erode district for this event. And then it fell upon the dean of the medical college and the joint director of health services. But eventually, we have very special guests here among us. I thank Dr. Shanmugasundaram and Dr. Venkatesh, both superintendents of our eminent institutions. It has been preordained that they should be here amongst us this day. And I'm glad to note that they have paid attention to the proceedings and have wished us well. With that, I thank the President, Dr. Sadanand, who is also a part of the organizing team, for having helped us organize this event. I thank Dr. Arun, the Secretary of Tamil Nadu Chapter. I thank Dr. Babu Balasingh, who is the Vice President of the Tamil Nadu Chapter. I thank Dr. Arul Prakash, who has recently become the President of the South Zone of Indian Psychiatric Society. It is an honor to have him among us. I think this is the first event he is attending in Tamil Nadu after being sworn in as the President of South Zone. So that is a nice event. I also thank Dr. P.P. Kannan, who is a representative of the state in the South Zone and who is doing phenomenal work in many areas. So I thank all the dignitaries here present here, especially the speakers who have taken our invitation and are here to give us great lectures. And I thank the postgraduates and everyone as well helped us organize this event. Thank you very much. With this, we end this inaugural event. And I welcome you all to have lunch with us shortly. Thank you.
Thank you, sir. Thank you all for your pleasant participation. Now let's break for lunch and assemble again at 2 p.m.